Hello. Hi, everyone. Thanks for joining us today. We're a little bit delayed in starting, so sorry about that, but I'm sure we'll keep on track through the day. For those of you who don't know me, I'm Becky, Rebecca Sanders. I'm the chair and founder of Lipodystrophy UK. Thanks very much. Most of you will be familiar with Siobhan. I don't know where she is. I wanted to didn't. Oh, there she is. So Siobhan's done a fantastic job of organising today. She's one of our trustees on the charity. For future reference, we're always looking for more support. So if anybody wants to get involved with the charity, then please speak to us. Lipodystrophy UK was born as a charity in 2017. And there was a lot of work done informally before that date. In fact, maybe 17 years before. Oh no, not 17, 7 years before, from about 2010, kind of been involved in patient days, working with Adam Brooks. And in 2017, we formalised to open this charity, and the reason we did that was because we felt that with charitable status we'd be able to gain funding to be able to do fantastic things like this today. So we're very grateful to have received funding from 2 different pharmaceutical companies to allow us to be here today, and I'm glad that you're all here to join us. I'm not going to waffle on too much. I just kind of introduce the day. So we've got talks both from medical professionals, most of which you might be familiar with because we've got several of the team here from Adam Brooks, both the clinical doctors as well as dietitians and nurses. But we also have talks from other specialists talking about body image and body confidence, about mental health and well-being, and exercise and living with lipodystrophy, and some of the studies that we've been involved with, for example, the fatigue study that some of you again may be aware of. So hopefully it'll be a day of lots of information, but not too much overload on the science side of things. There's also lots of practical tips and things to share. And I think I'm not alone in saying that the most benefit, certainly I've gained from days like this, is actually meeting other people that are affected by lipodystrophy, whether it's other patients or carers, partners, parents, etc. And that has really enriched my experience, and I hope it does the same for you. I'm going to leave it there. I'll catch up with you at the end. We've got refreshments outside if you want to pop out and get anything during the day. We've got breaks during the agenda, which I think you've all got in your packs. And we'll join for lunch at around 1 o'clock, and enjoy the day. First of all, I'm going to introduce you to Kimberly Littlemore. Kimberly has been working, is working with Leanne, who some of you may remember from the service a long time ago, but has now moved on to greener pastures in Wales. And they are producing a lipodystrophy film for information both for patients and clinicians. And so Kimberly's going to introduce a little bit, but anybody who wants to get involved in that during the day, please feel free. The more voices we've got, the better, the more awareness we can raise. So I'll hand it over to Kimberly. Thank you very much.
Thanks, Rebecca. You've done the job for me. I have very little more to say. So my name's Kimberly. I'm a former BBC producer, and now I make films for the NHS, mostly for people living with chronic conditions. And NHS Wales have invited us to make this film about lipodystrophy, which I'm really, really pleased to do. And the purpose of it, it's a film to show to people who've just received a diagnosis. It's for healthcare professionals who maybe are not familiar with lipodystrophy to understand, recognise and learn more about it, and to generally raise awareness. And of course, the experts on this, apart from the esteemed company in the front row, are all of you. And so what we'd really, really like is to hear from you, if you'd be so kind, to come and share with us your experiences, your advice, your expertise, so that we can intercut that into a film about defining what lipodystrophy is, but also perhaps to create little nuggets of things that you tell me that we can share. And these things will be available through the health system and on Lipodystrophy UK website. So we're filming across the way in the lounge. So you cross the little pedestrian crossing, go slightly to the left, and there's a big doorway there, and straight across from there is a lovely lounge, and we've set up a green screen. I've got a very lovely cameraman called Steve, and so if at any point during the day you've got 15 minutes, 20 minutes, and you think, oh, now's a good time, we'll be available all through the lunch, all through the breaks. I'm sure you'll want to listen to all the talks, but if there was one that wasn't appropriate or of such interest to you, do come over and see us, and I'd be delighted to have a chat. And we try and there's a couple of the ladies, I know Vicky has been in already and had a chat, and Rosie's been in to see us, and so hopefully they can testify that it wasn't too scary or horrible. It was all right. Thank you. So, please do come and do that, because I think it'll be incredibly valuable for others to hear from you. I think that's it, other than to introduce you to Leanne, who's my colleague.
Good morning. It's so lovely to be here and see some familiar faces. I'm really pleased to be here. So I now work in Wales, but I did work in the service in Cambridge in 2017, 2018. And when I went back to Wales, I now work in genetic, monogenic diabetes. But what I was always struck by was the lack of awareness around lipodystrophy. So I always hope to be able to do something to raise awareness. So fortunately, we got some funding, we're working with Kim, and that's why we're here today, to actually make this film that we hope will be shared with people living with lipodystrophy, demonstrating your experience, but also with healthcare professionals, because we know that sometimes people take a long time to be diagnosed, and we want to raise awareness. So I'm going to be around all day. Please come and talk to me. If you want to be part of the filming, you're very welcome, and I'll do everything to get you in there and take you over. If you don't want to, you just want to have a chat, please come and chat. But I'm around all day, and it's lovely to see you all. And thank you, Lipodystrophy UK, for inviting us.
So thank you very much, and please do get involved if you can. The more voices we've got, the better. So now I'm going to introduce our first speaker, and it's Dr. Anna Steers. Again, many of you will be familiar with Anna from the service in Adelaide.
My doctor. Pardon? My doctor at Cambridge. Well, I'm blowed.
Have you got a thing to do the slides, please?
Well. Anna Steers.
Well, yeah, you should have mentioned that. Bloody hell.
So I can do it from here.
Can you hear me okay? Yeah. Thanks very much for inviting me to speak today. I'm overwhelmed, to be honest, to see all of you here, and it's just fantastic. If you have any questions as I speak, just feel free to interject, and if not, we can take questions at the end. I'm going to start off, and then Rachel's going to join me to talk about the paediatric service. And so it's just an update about our service, really. So the overview of what I'm going to speak about is what is the National Severe Insulin Resistance Service? What are our objectives, or what have NHS England asked us to do? How many patients do we see, and where do they live? Hot topics and issues that we're having at the moment. And then, as I said, Rachel will speak about the children's service, and then we'll speak a bit about patient feedback and do some questions and answers. So the service is a specialised or highly specialised NHS service for adults and children with lipodystrophy and other causes of insulin resistance. But the lipodystrophy patients make up the majority, I would say about 3/4 of the patients we see. And it was initially commissioned in 2011 by the National Specialised Commissioning Team that don't exist anymore. And NHS England took over responsibility for the service. And the service was initially I think the Specialised Commission team were approached by Professor Sir Steve O'Reilly and David Savage and Rob Semple for funding, and that was before I joined the team. And the service is based at Adam Brooks in Cambridge, which isn't necessarily the easiest place to get to, so I apologise for that. And Prof Semple has now moved to Edinburgh, and so he sees some patients in Scotland, and then there's a colleague of Leanne's in Wales who sees patients in Wales as well. So. So the funding from NHS England is for people who live in England, and patients from other parts of the United Kingdom have to apply for funding, or their healthcare providers have to apply, but we haven't had anybody turned down. So it's just a bit more paperwork, but I don't think it's a massive barrier. And so we've got a website, which is part of the Adam Brooks website, with information for referring clinicians. And so clinicians can refer, we have a form for them to fill in with a bit of information about the patients. And then sometimes people refer themselves to the service, but we prefer it to come from the GP or the diabetes consultant or something, because they have a bit more background about the patient, and it's kind of polite for us to tell people that we're seeing you. So the objectives of the service are initially to provide a diagnosis to all patients with lipodystrophy or severe insulin resistance. And then once the diagnosis is made, to deliver specialist dietetic care and nursing care, and then to provide people with drug therapies appropriate to them. And we have funding for medications like metroleptin. We're the only centre in the UK that can provide metroleptin therapy. And then also it's to better inform people, patients and their carers, about these rare conditions. So this meeting is a good example of that. And so the structure of the service is we have a weekly or sometimes twice a month clinic in both adults and paediatrics. We say it's not a very big service, so we see about 50 new people and 200 follow-up patients per year. We offer genetic and biochemical diagnostic testing, and then, as I said, access to these specialised medical therapies, and also, of course, dietary therapy, bariatric surgery, etc. And then we have a monthly meeting, and we used to all meet in a room together, but during COVID we weren't allowed to do that, so we now meet by Zoom. And hopefully we can start meeting in person again. So the picture is just a picture of our happy Zoom meeting that we have once a month. And we all attend that. And then occasionally we have inpatients. So we are funded. If somebody needs to come in to start metroleptin, which isn't very often, because usually we can do it as an outpatient, or for some other reason, we can admit people for a few days. But we try and avoid that if possible. And so this is the number of referrals that we've had over the years. I thought you might just be interested in seeing how many patients are referred and how it's kind of stayed pretty steady. So 40 to 60 people per year are referred. And on the other side is the how long people have to wait before they see us. And if anything's urgent, we can always see urgent patients at short notice. So we always try and fit people in if it's urgent. And our waiting times, we had a bit of a blip in 2014-15, and that's when we opened our second monthly clinic to try and bring down the waiting times. And so now the average is about 6 weeks, sometimes a bit longer, but so that's not too bad, I hope. And this is where the patients come from. So these are maps that we've provided to NHS England to show the spread of the referrals. We think there's a little bit of a gap in the West Midlands, kind of Birmingham, Oxford area, but there is a lipodystrophy clinic run from Oxford by Professor Carp. Do you? Yes. So we do, and I'm actually having a Zoom meeting with Professor Carp on Monday. So yeah. So Professor Carp can't yet prescribe metroleptin, so that's what we're going to talk about, a patient who needs metroleptin. But yeah. So I think you might be able to spot yourselves on that map. And this is our caseload. So we obviously, sometimes we discharge people when they have a good local team that can look after them. And then we have open access. So if people want to come back to us, they can. So we discharge about 40 patients per year. So we're gradually rising into the kind of 200s. And the definition of a rare service is, I think, a service with less than about 300 patients, 400 patients. So we're kind of meeting that criteria still. And obviously we have more adults than children. So just moving on to the issues. So the major issue, as you can all imagine, in the last couple of years has been COVID. And although the government seems to think it's all over, it is still a problem for us. And so we still have a lot of patients on our inpatient ward with COVID. And it still means that sometimes clinics have to be cancelled if staff are unwell and things, because we're not allowed to come in. But we've managed, I think, to deal with it okay. So on occasion, so when I had COVID, Charlotte did the clinics, and we all kind of cover for each other and hopefully keep everything going. And we've had a reduction in the face-to-face consultation. So initially, the hospital said we weren't allowed to see anybody face-to-face. And now we're allowed to do what we want. So people can come by video, by phone, or face to face. Let people decide what they want to do. Our phlebotomy service closed in our kind of little area in the diabetes centre. So the nurses in the clinic now do the bloods. But because there's now more people coming in face to face, they're getting a bit stretched. And so Charlotte's training up to do blood taking. Hopefully that will help. Obviously, if we have a virtual consultation, someone's on a video, we can't do any blood tests. And so we've been battling to get GPs to send us the blood test results. And we have variable, success with that. So if you want to send us your blood test results, that's really helpful. We can just keep a note of them. And obviously, we couldn't meet for face-to-face meetings, but we're meeting by Zoom, so it's not a major problem. So other issues, when we did our patient feedback a few years ago, a lot of people said that they wanted some psychological and emotional support. And so we put a bid in to the Addenbrooke's Charitable Trust for funding for psychologists, I think a day or two a week. But there's a national shortage of psychologists. If anyone wants a job, clinical psychology is the place to go. There aren't enough of them and we cannot recruit anybody. So it's a bit frustrating. We've got the money, but we can't find a person. The Diabetes Centre does have a psychology network of support, so you can see a psychologist, but they're not a specialist in lipodystrophy, and we want someone who knows about lipodystrophy. And we also think a psychologist will help support us as a team as well. So, so if you know anyone who's interested, there's a job at Addenbrooke's. Another issue we've had is the delay in genetic testing. I think that was a problem in the Addenbrooke's lab and COVID, and that people were waiting over 18 months to get their genetics results back. And that seems to have improved. So hopefully that's not a problem anymore. There's something new called the Genomics Hubs, which is funded by NHS England, which means that specialists throughout the whole country can do genetic testing now, and it's funded by NHS England. So hopefully that will help speed up diagnosis if the labs are a bit quicker in getting the reports out. So that might mean that people can have a diagnosis in their local team and then come to us for specialist advice. We're obviously keen to make sure everybody knows about our service and that patients are referred to us if they need to see us. And that's been tricky because there's no kind of database of all the diabetes and endocrine services in the UK. There's nobody who holds a central kind of database of it all. But we've managed to join in with the Monogenic Diabetes Network, which is run, I don't know if anybody's heard of that, from Exeter, who are a centre that do monogenic MODY diabetes. And so we've become part of that network. And I think we're managing to reach out to more people now through that. And obviously we go to conferences and do webinars, etc. We've talked about the short film. I think that will be excellent and a really good thing for both healthcare professionals and for patients. And then the issue I put on the bottom there is industrial action. So we've had to cancel a couple of clinics for the nurses' strikes, and now we're having to cancel for the doctors' strikes. So I'm going to be the junior doctor on the ward in 2 weeks' time for 3 days, and I'm having to cancel the clinic. So I apologise if we're, moving your clinic dates, but I can't do anything about that, unfortunately. Charlotte and the educators will run the clinics by telephone, but we can't see people face to face on those strike days. And just talking, this is a short slide because David Savage is going to speak about research things coming up, but this is just emerging therapies and things that I think are on the horizon. So the government body NICE, who decide about funding for things in the NHS, have recently put out new guidelines for people to get access to continuous glucose monitors. So I'm sure a lot of you in the audience already have continuous glucose monitors, but might have had to go through a little bit of a process to get it with exceptional funding applications. And now this is becoming more available for people with non-type 1 diabetes. I think it varies where you live in different CCGs, the access seems to vary, but I think if you think you would like a continuous glucose monitor, ask your healthcare professionals or contact us. Yeah, don't give up, because I think the more noise you make, the more access people will get. No. Yeah. 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 But it's not fair because it's different in different parts of the country. I think Cambridgeshire are actually quite it's quite hard to get them funded in Cambridgeshire, and other parts of the country the GPs are just prescribing them. Yeah, yeah. So it is an issue. But I think within 5 years, everyone who wants one will have one. That's my guess. There's a couple of new medications. I'm not going to say much about these. I personally actually don't have any experience with these yet, but they're both triglyceride lowering agents, and they're available through the lipid clinics. And the second one, David's going to speak out about a bit. And at the moment, they're only, I think they're only available for people with what's called a familial chylomicronemia syndrome, which is another syndrome which is rare and causes high triglycerides. But I think those agents will become more available. So these are for adults. I will hand over now to Rachel, who will talk about the children's service, and then we'll take questions at the end, unless anyone's got any questions for me.
Yeah, thanks. Hi everyone. Thanks, Anna. So I've just got a couple of slides really just to kind of talk to about the children's service. It's quite different than the adult clinic. So as Anna showed, we've got sort of mid-30s of children and young people that come to our clinic, and they've got a variety of different either forms of lipodystrophy or other forms of severe insulin resistance. And fortunately, with the majority of patients tend not to have comorbidities such as diabetes, etc., etc. So actually, what we do for the children is quite different, I think, in that we kind of really monitor to see how the blood tests are changing, what's happening over time, and we liaise with colleagues around the country really to try and facilitate that. It's sometimes a bit clunky. Many of my patients will know that the communication between different hospitals is not always perfect, but so largely it's around monitoring, building relationships, trying to encourage good habits around diet, etc., and then intervening as needed, and also being advocates for our patients, I hope, in school and college and all those other environments. That's what we aim to do. So this is our clinic, much nicer, we think, than the adult clinic. And Angela, our fabulous play specialist, is over this morning with the children and young people. So that's the Western Centre. I think the geography is brilliant because literally Anna's next door. So the teams are literally either side of the lifts. So that means that we can kind of talk about patients, share expertise, get advice, just really talk things through. And also when children and young people get to the age where they're ready to move to the adult service, we often try and do that in a kind of joint way. It's COVID. I think we're all getting a bit sick of the because COVID thing, aren't we? But COVID kind of scuppered that a bit. But what we aim to try and do is kind of meet with nurses, dietitians and clinicians from both sides before that move. The other thing we really try and do is to have appointments for families. So if anyone is part of a family unit where there is more than one person affected, we cannot try and offer clinics on the same day because it's always a Tuesday for both sides. So if you find that your child's got an appointment 2 weeks after yours, please just ring up and we'll do our best to change that. So that's the lovely Western Centre. And just a comment as well about, I'm a paediatric hormone specialist, a paediatric endocrinologist, and that's a much smaller community than the adult diabetes community. So oftentimes the children and young people that we see have got really excellent support from a local endocrinologist. Not always, but also what tends to happen is that I will have almost a personal / professional relationship with those endocrinologists because there's hardly any of us in the country. We're a bit of a niche specialty. So that's just that. So this is the team, and I've done, so Angela is so it's alphabetical by first name. So Angela is our play specialist. Cleena is our dietitian. She's not here today. We've got Ellie, who's used to work in our service. Cleena is currently in South Africa with a bunch of type 1 diabetic teenagers. I'm not sure whether I'm jealous or not, but they're on a kind of a trip organised by the Children's Diabetes Network. Then we've got Hannah, who's our secretary. So all the letters come out from Hannah. That's a much younger me. Raina is in the middle on the bottom row. She organises all the appointments, and then Sam, who is our CNS. So we can't avoid the blood test really, but we really do our best to try and make them as least bad as we can, if that makes sense. So that's really all I've got to say about paediatrics. So, and really now there's been quite a bit of change in terms of the staff, and now I think really we've got quite a settled team. I hope you've seen the same faces when you've come back, and we do our best with engagement from most families. I think we'd love your feedback on getting to us. You know, it's a long way from lots of places, Cambridge. It can be really expensive to get to. So that we worry that might be a barrier to engagement. We're working with one of our pharmaceutical company partners to develop some new resources for children who are starting on metroleptin. So it's like a pack with some resources and stuff, and which is really really exciting. Yeah, we also give talks. So I've got a few talks coming up this year, and again what we try and do is raise awareness. So generally I just go out and talk about how do you spot the person or the young person with lipodystrophy in your clinic, and what to look for and when to query it, particularly the partial forms, and that's a talk that I've done for a few years now, and I think it must be, well, people like it anyway, because I keep getting asked to give it again at bigger conferences. So, and there's also an international community. So we try and support paediatricians across Europe. So I'm meeting with someone from Norway next week who wants to start some children on metroleptin who hasn't done that before. So often with these rare conditions where we're learning as well, it's helpful to support each other. And so there's a real sense of community there. Our referrals are generally all appropriate. And actually, one of the things we did last year was we had a student, Jujuin, who looked at outcomes in children with partial lipodystrophy. So just looking at just the stuff we routinely collect, blood tests, etc., published, which is great. So that's informing the literature. One of the things I reflected on when I first started was actually for partial, we know what happens if you're diagnosed when you're an adult and you've already gone through that kind of process, but actually lots of the children and young people came to our service with a genetic diagnosis, and they were all very well. So trying to learn about what to expect and what's helpful, I think is a really important part of what we do. I've talked about that. I'm no good at sticking to discipline with slides, sorry. So yeah, travel times and prescribing for metroleptin is sometimes a bit clunky. So again, if you've got any feedback on that, we're trying to make it digital. Everything in Addenbrooke's you prescribe electronically, apart from metroleptin, which requires a signature in biro, and then a physically taking the prescription down to pharmacy. And there are many points in that process which can go wrong, not least me. But anyway, so that we do our best with that. Okay, so this is about feedback. So many of you have really supported the service by filling out feedback, and we acknowledge that can get slightly boring when you think, well, I said this last year. We would just really ask you to, if you can, keep filling it in. Because we're keen to learn and improve things where we can, but also every year we have a meeting with NHS England where we talk about the service and that sort of thing. That was very kindly supported by patients this year, which is a big improvement, I think. But it's just really to encourage you to keep, because if we can keep demonstrating year on year that patients are engaged, they find the service of value, then that will be part of the security and the longevity of the service that we offer. So please, if you get asked, just if you can, just make the time to fill that out. Most of you seem quite happy, which is good. And that's the kind of the things there. And as Anna said, one of the we try to respond to comments. So the voice asking for psychological support and wellbeing support was heard, but we just can't find a psychologist. So if anyone knows one who's free, then please let us know. So I think, yeah, if Anna's going to join me now, and we're just happy to take any questions, really.
I think Anne-Marie, our administrator, sent it out by email to everyone that we have email addresses for. And people who don't have an email address, we posted it, or Anne-Marie posted it. And then we put it in the patient newsletter that went to every patient. But I tried, one of those actually responses is me, actually. So seeing if it's worked. I didn't give myself a score, but I did see if it worked, because I thought maybe the link wasn't working. But we sent it 3 or 4 times. But I think we sent it to people who are new patients from 2019. So actually quite a few of those people had more than one appointment. So perhaps we'll just send it to everyone again next time. But, you know, we don't want to, it is a bit boring keeping getting feedback questionnaires. So, you know, we want to have balance between. Yeah, so if anyone's got any ideas, but
Well, is it a one-day thing, is it?
Yeah. Yeah, it's quite interesting.
Yeah, I'll bet. Yeah.
Yeah, just sort of saying, you know,
You
like,
record it anyway.
I don't know how to prevent that either.
it's just like totally on film. So, but I should come off of it in a minute.
In contact. Right.
The other thing we thought about is like a QR code in clinic or something that can sometimes that feels a bit kind of, you know, I'll stand over you while you fill out, you know, so it but that's another, although personally speaking, I can never work out how to scan a QR code.
No,
my children have to show me, but that's, so it's maybe a variety of different ways. Oh, that's it. Yeah.
Yeah, we do have phone numbers, so that's a good idea. Yeah.
I think we're not allowed to text, are we? Adam Brooks is a bit that. So what's so I know our educators in the young people's diabetes clinic are desperate to just WhatsApp the kids, or and we're not allowed to. I don't know why Adam Brooks says no. But I think the more we get feedback to say this would be useful and effective, because then, you know, that would be, so we can take that back. Thank you.
I think it's
Oh, wow. My chart, yeah. Yeah.
I think Ricky's writing that down.
Yeah. That would need to come from Lipodystrophy. We wouldn't be able to do that from Adam Brooks. Our data protection people would probably like never recover from something like that. But it's a really good idea.
We could probably send the questionnaire through my chart, though. Actually,
yeah, that's a good idea.
Yeah. So in Adam Brooks, we have an online system for patients attending Adam Brooks in general, where they can see their appointments. And well, the link to the iChart is sent through an email. So again, that might end up in junk. So everyone that comes, we send the link to MyChart, and then you put a code in, and it's quite easy to use. And then you can see all your results, your clinic appointments, and you can message through MyChart as well to us. So it's quite good.
And we can use.
Lost it.
Yep. Hi.
Yes.
Yeah. Yeah. Yeah, so psychologists are recruited by it's a different trust, so CPFT, so they're a community trust, and they are recruited by other psychologists. They're not recruited by us. And there's nationally, so we're short of a psychologist in the children's diabetes service as well. There's nationally just a shortage of people. Yeah. Yeah.
Yeah, we'll try that.
Yeah, thank you.
Thank you.
Yeah, lady at the back. I'm really sorry, I can't hear you.
I think we'd like someone with us,
Yeah.
really, that's come to our meetings and be in the clinic.
Oh, thank you.
Yeah. I think for new patients, we have to do the bloods in our lab. If you come with your results with you, they're not on our computer system. And so when we pull through the results to do the reports, etc., we have to put them all in manually. And sometimes then we don't get them either. So it's a little bit, so I prefer to have them done at the clinic. But if it's, and often we don't get them. So I think if you bring the results with you on a piece of paper, that's fine. But we spend a lot of time trying to chase results that we never get to see. So yeah, but you can certainly do that if you wish. Yeah.
And North East, I noticed when you did the maps there,
yeah,
very, very little in that area.
Yeah.
Can you self-refer it to the hospital? Looking at the list further.
Yeah, so you can send us a message, email or something, and then tell us a bit about yourself, and then I'll have a look at it and see whether I think that so sometimes we get inquiries from people that just don't have lipodystrophy and don't fit into the category of the service at all. And so in those patients, I might say, can you ask your GP to send me a letter about you so I can work out whether this is the right place for you to travel to.
Yeah.
So you're welcome to let us know about yourself, and then I can decide whether or not you can just come directly or I need a bit more information. But definitely, or you could message us and say, this is my consultant in the North East. Can you have a chat with them about whether I can come to your service?
You know, the mention in previous appointments about backbooks.
Yeah.
Cambridge and stuff, and between different doctors that I've spoken to,
yeah,
taking pictures and things like that. You said that you sent it to Cambridge, but then I've never had any actual response, or I've never been referred to the team.
Yeah. So there's that on our website. There's a referral form. Just ask them to fill it in and send it to us. And yeah. Yeah. Yeah, just send us a message. Yeah. Yeah. Just email us and we'll sort something out. Yeah.
Just a quick question about the drugs.
Yes.
What is the best place to look to actually get, reliable information on those drugs, rather than just Googling it?
So there's a thing called the Electronic Medicines Compendium. I can send you the link to it, and that has all the license information about every drug. Yeah. So it'll include all the side effects, mechanism of action, blah blah blah. Yeah. What that won't have is whether the drug is funded for use in the UK, but it will have what patients it's indicated for. So it might be going through the NICE process, but you can probably check that on the NICE website. Yeah. Yeah. Any other questions, or we should move on? I think David's next. Yeah. Thanks, everyone. Thank you.
Thank you both, Anna and Rachel. That's really informative. And next we've got Professor David Savage, who's going to talk a bit about research.
Thanks very much, Becky. Good morning, everyone. Yes, so my name's David. I'm a medically trained doctor, although I basically work in research 4.5 days a week. I still do about half a day a week in normal clinical practice. I've been working in lipodystrophy in Cambridge for about the last 20 years. Steve O'Reilly is the head of our department. He's approaching retirement, although he's still very active. He'd initiated interest in lipodystrophies in Cambridge, and then I joined him shortly afterwards. Rob Semple has also worked with Steve for many years. Becky was actually a scientist with us as well. So I'm also conscious that I'm speaking to people, probably quite a spectrum. Some of you probably are scientists or have been scientists, whereas others have not had much exposure to research and the scientific aspects of lipodystrophy. So apologies, it's quite difficult to balance it to interest all of you, but we can try and discuss things afterwards across the whole spectrum. So I put up this image on the top here, in case they're amongst you. Clearly, I wouldn't be invited if the Lipodystrophy UK community wasn't engaged in research. So I realize that many of you are very pro-research, and Lipodystrophy UK is encouraging research, but others of you might still feel that research involves kind of guinea pigs and looking after you in that fashion, trying to take information from you. So I'm not suggesting that there's no research that doesn't fall under that category, but from my perspective, I think what you really want is pretty much all doctors should be doing research, basically. We wouldn't make progress in understanding or treating conditions if we didn't do research. So normal medical practice, when a person comes to see me because they've got a problem, particularly say lipodystrophy, they've probably been to a couple of other doctors who didn't know what it was about. So they'll come and see you. Then you actually want a doctor who's thinking about the problem. And so I would like you to understand research as a part of normal medical practice. We can't actually make a diagnosis unless we investigate and try and find out what's going on. And until you know all the genes that are linked to lipodystrophy, you have to do research to try and find new genes. And the same goes to therapies. You can't develop a new therapy unless you have some idea that there's a need and then test it. So yeah, some of you may be on this end in terms of thinking about research, but certainly we try not to use people in that way, but we do need to learn from patients if we're going to make progress. So yes, so just to quickly introduce that concept in the background. Then for what I'm going to talk to you about today, I'm just going to give a little bit of general background about lipodystrophy. I'm going to tell you something about the progress in understanding the genetic basis of some forms of lipodystrophy, a quick overview about treatment approaches, and then just give you a kind of list of the type of research we're involved in Cambridge at the moment. So lipodystrophy, the names lipo, fat, and dystrophy, disease of fat, is about all lipodystrophies involve, at least in part, some problem with fat cells. Either you have no fat cells or you have some and they don't work properly, basically. So this is just a quick introduction to the way I think about what fat cells are really there for. They're essentially there to store excess energy when it's available. And I use this image, this kind of evolutionary schematic illustration to make a particular point. So for most of human evolution, ancestral species had to survive in an environment where it was very, very difficult to get enough energy to survive and reproduce. It was hard to stay alive, basically like wild animals living in Africa today. It's very difficult to get enough food to survive. So you're actually on the brink of starvation. You're not at threat of overeating or overnourishment or obesity. It doesn't happen in the wild. And so for hundreds of thousands of years, humans have had to survive in environments where it was very difficult to find enough food. And so what that has meant is that our brains are hardwired to eat and to find food all the time. And so in modern environment where food is relatively cheap, never mind inflation, it's still, in terms of having to run hundreds of miles to find something to eat, it's relatively cheap. And it's very high in calorie content and very tasty. So it's not surprising that the challenge for modern humans has shifted to how to survive and cope with such easily available and excess calories. And so that's what's fueling the obesity epidemic all over the globe. And clearly obesity, overeating, ultimately our fat cells increase in number and size, but eventually many people are overeating so much that our adipose tissue just can't cope, even if you don't have lipodystrophy. And that's when you then become insulin resistant, get type 2 diabetes, have problems with cholesterol and triglycerides, fatty liver, predisposed to heart disease, polycystic ovary syndrome in women, which is associated with infertility. So in the case of lipodystrophy, where, for example, this child with a generalized form of lipodystrophy has no functioning fat cells, you have a huge problem because you have nowhere to store the excess calories that you might eat at certain times. And just to point out to you how important fat cells are for storing excess calories, all humans and animals can only store excess calories in two ways. One is glycogen, which is a carbohydrate, and the other is triglyceride, which is neutral lipid or fat. And this graph just shows you that a healthy adult human can only store about 6 megajoules of energy as carbohydrate or glycogen, whereas even a thin adult stores about 100-fold more, so 600 to 800 megajoules. That's a perfectly healthy, not obese person, not with lipodystrophy. And so if you have lipodystrophy, if you have generalized lipodystrophy, you pretty much have nowhere for all this excess energy to go because it can't go into fat cells. And what happens then is that it accumulates in the liver and other organs, and those organs are not designed to handle that much excess energy as triglyceride. And because they can't handle it properly, you get fatty liver, you become insulin resistant and predisposed to type 2 diabetes. And if you have enough fat in your liver for long enough, it doesn't just make you insulin resistant, it also damages the liver. So you're then prone to liver disease over sufficient time. So that's the crux of it, yeah. It's a problem in obesity, but in lipodystrophy, you either have no fat or very little, and then there's nowhere to store it. And remember, on top of that, you've got a brain that's hardwired, that's telling you you need to eat whenever it's available and making you feel hungry. So it's a very big challenge, basically, for all people with lipodystrophy. And it's a challenge that we as researchers are trying to understand better so that we can find new ways of treating it more effectively. Okay, so just to say a couple of things about fat distribution and how we think of lipodystrophy nowadays in terms of fat distribution. So I think most people will be aware of the idea that in healthy adults, it's most obvious in women, the normal pattern of fat distribution is so-called pear-shaped fat distribution. In other words, most of the fat should accumulate around the femorogluteal, or the kind of hip and buttocks, upper thighs, hip and buttocks region. That's the kind of healthy place for excess adipose tissue. There are a reasonable number of women who are not known to have lipodystrophy, who rather than the normal pear-shaped distribution tend to accumulate fat centrally on the abdominal region, and men, almost all men, tend to follow this pattern. And that's so-called apple-shaped fat distribution, with much less on the femorogluteal and much more on centrally. So that's kind of just in the normal distribution of the population. So when we get to lipodystrophy, we think that partial lipodystrophy, some forms of partial lipodystrophy, particularly this one, which we tend to call FPLD1, familial partial lipodystrophy type 1, is really just an extension of that spectrum. So these people have almost no fat on their legs and quite a lot of fat centrally on their abdomen, basically. And that's we have shown that genetically, basically, these different patterns are determined by genes, but not just one genetic change. These are many genetic variants contributing to that pattern. And so we think that this entity called familial partial lipodystrophy, which is probably the most common form of partial lipodystrophy out there, is in fact just an extreme version of this. It's not a single gene abnormality. There are many genetic abnormalities that contribute to it. So we think, and now we recognize that this is actually a form of subtle lipodystrophy. The main problem here is that these women can't store fat properly on their legs, which is where it's supposed to be stored. So lipodystrophy, partial lipodystrophy, is part of that spectrum, basically. And that's just illustrated in another way here. As your lipodystrophy gets more severe, so this would be healthy, pear-shaped. That's still healthy. General population, apple shape. Here's FPLD1, where you've got really a lot of excess central fat and none on your legs. And then other forms of partial lipodystrophy, and then generalized. So as you have less and less normally functioning fat, so you get more insulin resistant and have more severe metabolic disease, basically. Okay, and this is just to illustrate this as a mouse experiment. This is not done in my lab, so we do mouse experiments, but this is not from my lab. sorry for the picture if people find this offensive, but this is a healthy mouse with its skin removed. It's dead now, but it was healthy until the skin is off. It has normal fat depots, whereas this is a genetically engineered lipodystrophic mouse that has no normal fat cell function. And this is just to show you, if you switch these mice, they normally eat a very carbohydrate-rich diet called chow diet in the lab. If you switch them to a high-fat diet, they like it and eat more. But this is what happens to their blood glucose. So if you take in the black lines, there's a wild-type mouse on a chow diet, low-fat or a high-fat, it doesn't make much difference. Whereas the lipodystrophic mouse's glucose was here. And then after 2 days switching to the high-fat diet, its glucose has gone from 10 to 30, basically. So it just cannot cope with the excess calories. And that's the same problem that humans with lipodystrophy face. If you have generalized lipodystrophy, you'll face as an extreme a problem if you're overeating. And if you have partial, it's less extreme, but it's the same type of problem, basically. Okay, so just to tell you about some progress with research. So the first genes were formally shown to link to specific types of lipodystrophy in about 1999, 2000. So until then, we didn't know specific genetic causes of any forms of lipodystrophy. So in the 25 years since that time, and when I say we, I mean all researchers around the world. This is not just Cambridge. We've contributed, but there have been many groups studying it around the world. We're now up to just under 20 different known genetic causes of lipodystrophy. And we probably know the genetic basis of about 90% of cases of lipodystrophy globally. So there's been a lot of progress in terms of understanding the genetic basis. That means you can get a more definitive diagnosis. It means you can get family members tested. And in some cases, you can do prenatal testing if that was relevant to you. And it's helping us understand the condition. I'm not sure that any of this is directly translated into a gene therapy yet. Lipodystrophy is kind of in the balance where if you have a genetic condition that's going to be lethal within the first couple of years of life, you're going to be more keen to try a gene therapy where you actually try and manipulate your own genes. There are risks associated with that. Lipodystrophy is kind of intermediate. Are you prepared to risk having gene therapy with its associated uncertainty? So I'm not aware of anyone actually doing gene therapy directly for lipodystrophies to date. That's not to say it won't be done, but it hasn't been done to my knowledge yet. But anyway, so in the last 25 years, these are, I'm not going to go through the details, but there are at least 4 genes strongly linked to different forms of generalized lipodystrophy, at least 7 to different forms of partial lipodystrophy. There are quite a few other syndromes where lipodystrophy is an element of a condition which has additional features with it. This is one of the recent ones that we were involved in figuring out. These people have this very unpleasant excess adipose overgrowth in their upper body, and then they have lipodystrophic legs, and they also get a neuropathy. They get nerve damage, which is not just related to the diabetes, it's actually part of the genetic condition. So there are, at least 8. This isn't meant to be a comprehensive list, but this is reasonably up to date. At least 8 different genetic conditions where they're strongly associated with other features. And then there's some forms of so-called acquired lipodystrophy where people are prone to autoimmune disease, and we think the immune system actually attacks the fat cells. And so those are other forms of partial and generalized lipodystrophy as well. So there is a lot of progress, and we and others are still working to identify the other genes, the other 10% of the population where we don't know the genes associated. In terms of medications, I don't think there's massive progress that's specific to lipodystrophy. The thing with lipodystrophy is that where there's progress in drugs for obesity, some of those drugs are worth considering in people with lipodystrophy, because a big part of what we're trying to do is help people with lipodystrophy eat less. And that's what people are trying to do for people who are obese as well. So I'll mention a couple of drugs along those lines. This is this agent called volanesorsen, which is specifically for high triglycerides. So it doesn't affect diabetes at all. There's been a study now with about 40 people. Most of them were treated in America. It didn't have any effect on HbA1c or on glucose control in people who had diabetes, but it lowered triglycerides by somewhere around 80%, 60 to 80%. So it was pretty helpful in lowering triglycerides. It's an injectable therapy. once weekly at the moment. It did have some side effects affecting the blood cells, platelet count specifically. So they're working on a slight modification to avoid that side effect. But it's something, it's not yet available in conventional diabetic and endocrine clinics. As Anna mentioned, it is used for a rare form of very high triglycerides unrelated to lipodystrophy. So I suspect it will come along, hopefully in the better formulation that doesn't have the side effects of causing low platelets for people where other approaches are not being effective in helping them to lower their triglycerides enough. On the weight loss side, which, as I said, is part of what the weight loss, the obesity community is pretty excited by the new drugs that have become available for obesity. And these should certainly be considered in some people with partial lipodystrophy in particular. I'm not sure they're really going to help much if you've got generalized lipodystrophy, but in some forms of partial lipodystrophy, they're worth considering. And so this drug, for example, acts on GLP-1 for people who are interested in the details, but it lowers body weight by like 15 to 20%. And this is over the course of over a year. So this is sustained weight loss. So this would be very helpful in many people with partial lipodystrophy. The main side effect from this is nausea, which some people experience. Often it goes away and improves with time. And clearly, I mean, many people are managing to take it for well over a year. So many people can adjust to that side effect. This is another one, again, primarily used in people who are overweight. But again, I think worth thinking about in partial lipodystrophy in particular. This one's achieving over 20% at the top dose in terms of weight loss over more than a year. So I think these are things that Anna and us in general would think about. And if you're interested in thinking about them, then they might be helpful in some people, particularly with partial life. So for example, FPLD1 type patients, this would be worth thinking about. Okay, low calorie diets. So this is a headline. These are now quite big news in the NHS group in Newcastle who is using very low calorie diets, and just in general, overweight people with type 2 diabetes with fantastic results. We are doing a study in Cambridge, which has been delayed because of COVID and getting the product, but we are doing it. It works very well in terms of losing weight and improving diabetes and lipid control, but it's very hard to stick to if you've got lipodystrophy and a relatively low leptin level. So it's a real challenge. But they do work and they are an option. They're just hard to sustain over time. So allied to that is weight loss surgery. Again, we've had a few patients who've had weight loss surgery. This is just it's not for everyone, but this is a patient. So at the time of her surgery, she was in her 40s, type 2 diabetes for 16 years, dyslipidemia, high triglycerides, fatty liver disease, on insulin, a whole host of medication, and she had familial partial lipodystrophy type 1. This was her weight and her HbA1c. It's a 12%, very high. It should be less than 6-7%. 1 year later, she had weight loss surgery or bariatric surgery, gastric bypass. She'd lost almost 20 kilograms in weight. Diabetes dramatically improved. She'd come off these drugs, triglycerides better. So it does work. There are issues with dealing with the consequences of weight loss surgery over time. It's not for everyone, but it is very helpful in people in terms of the metabolic disease. It does not reverse, obviously, the appearance elements of lipodystrophy, but it helps a lot with the metabolic diabetes, high triglycerides aspects of lipodystrophy. This is one of our patients. I don't know that she's here today. She had FPLD1. This was her kind of glucose levels, 12, 13. Then she had weight loss surgery within 2 or 3 days off insulin. And you can see the big drop in her blood sugar, basically. Wow. So it does help. It's not without problems. It's a big operation, but it is very helpful in that. Okay, a quick word about leptin. So for anyone who hasn't heard of leptin, leptin is a hormone produced by fat cells that has a strong effect on regulating appetite. And if you lack leptin, because you have lipodystrophy, either partial or generalized, your leptin will be too low, it tends to make you feel very hungry. So leptin can be now given as an injectable therapy, typically once a day, and it's very helpful for the metabolic complications. It doesn't bring the fat back, it just helps the appetite control. So it is available in the UK now on the NHS for people with generalized and partial lipodystrophy. And partial lipodystrophy, it's second-line therapy. So the NHS suggests you need to have tried regular therapies first, because it's not as effective as it is in patients with generalized lipodystrophy. Amrit is the company that's been producing it at the moment. They've actually just been bought out by another company. And so lipodystrophy and leptin has had a bit of a problem because it's an expensive drug and there's so few people using it. Companies keep selling it. And so it's a bit of a worry. It's hard to get around that. But for now, it is available. So Amrit's doing a study in partial lipodystrophy to actually better document the benefits of leptin, mainly for people starting at for afresh. And so Anna's going to be leading that study in Cambridge. So she'll be talking to you about, it's basically just monitoring your progress if you're taking leptin as a starter. Regeneron is a company in the US that's developed an antibody that does pretty much what leptin does. It binds to the receptor for leptin and kind of does the same thing. It's a bit of a faff, this therapy. It is another option. You only have to inject once a week, so it's less than daily. But the moment it actually has to go in through a drip, you'd have to have a nurse come and give it to you. So it's worth thinking about. They're probably planning some studies and people will be invited to participate. It'll be entirely up to you whether you want to or not. But they're trying different formulations of enhancing leptin action or promoting leptin action. Other research that's going on. So fatigue, in addition to people telling us that they wanted psychology support, people have been telling us for years that fatigue was a big problem. And this was really research initiated by the patient body, basically. So this has now been funded. It's just getting the final elements of ethics. And I think someone is talking later in the day about this. This will be a kind of questionnaire. The goal is to try and understand what is causing fatigue in people with lipodystrophy. Is it one thing or is it different things in different types of lipodystrophy, to get a better understanding of what's causing it, so that then we can try and work with fatigue experts. There are people like that in the UK to try and think of new ways to alleviate the fatigue. Other things just to mention, ECLIP is a European consortium for lipodystrophy. So that, as Anna mentioned, the doctors across many European countries, pretty much all, I think, who see people with lipodystrophy are pretty well connected. It was initiated by a group in Spain, but we're all pretty well joined up. And they've established a registry, which is just a collection of information, anonymized information on people across Europe. And the goal is, because it's such a rare disease, to share expertise. So it's taken, we've had ethics approval to invite people to take part in the UK for years, but because of Brexit, there was a legal issue and we couldn't actually activate the study. Anyway, that is finally activated now. And so Ekaterina will be talking a bit more about ECLIP later. But that's basically a registry, and anyone who comes to our service is invited to sign up to it. It's not really our research. It's really a database of all people with lipodystrophy to try and increase and share expertise across the whole of Europe. And so we would need your consent, and then we would load up your data in an anonymized form to that database. But it's entirely up to you whether you want to participate or not. A new thing, essentially, we would like to invite everyone who comes to the clinic to take part in some form of research. And so if you're having blood tests, we would like to store some extra serum, which is what we derive from your blood, basically. And so normally, if you have blood tests, you might give 20 mils of blood. They're going to be asking, do you want to give an extra 10, which will be stored? And that will just be stored over years, so that when we find some new molecule that we want to test, is this too high or too low in lipodystrophy, or does it change in response to this treatment? Then we'll have that database of serum and plasma from people to test for these new molecules, basically. So again, pretty much everyone will be invited. That's just now been finally approved to take part, and it's entirely up to you. Basically, there's no obligation. You just decide whether you'd like to take part or not. So that's called a repository. We invite pretty much everyone already to take part in genetics, either for known genes or for research to find new genes if we don't know the basis. This is one new study. So I said to you earlier that if you don't store fat in your fat cells, it ends up in your muscle and liver. And this is a new study involving MRI. One of my colleagues, who's an MR specialist at Addenbrooke's, she has set this study up, Alison Slay. And essentially, she's trying to understand the molecular pathways. When your fat in your diet can't get into your fat cells, why does it get in your accumulate in your liver and muscle? What is the pathway? It's really an early study to try and understand that. If we understood the pathway, then we might be able to block it, basically. So that's the kind of the study. It involves an MRI, which some of you will have had, is uncomfortable and lying still in an MRI scanner for a couple of hours, some blood samples, heavy water, which is just water with a stable isotope. There's nothing dangerous about it. And then a second scan a few days later. So again, we'll be telling people about this. And if you're interested, we've got information leaflets and that kind of thing. But that's very early days research, trying to understand mechanisms of what's going on. And then finally, just a lot, people are working like me and my lab, Rob Semple, many other groups around the world, still trying to understand. We know many of the genes, but we don't know exactly how those genes affect your fat cells, what they do in them, and why they're not working properly. So there's a lot of work going on to understand adipose or fat cell function better. We know quite a lot about the genes involved in regulating where fat goes, fat distribution, but there's a lot of ongoing work around that worldwide. There are actually companies that are working on the idea of trying to keep triglyceride in fat cells where it's supposed to be. And that would be helpful for people with some forms of partial lipodystrophy. So there are dedicated companies already working on that. Third Rock Ventures is one company with that goal. You may have heard of them. So just to make you aware, there are people trying to do things which we think will be useful for people with lipodystrophy. And in terms of, most of what we're doing at the moment is to control energy intake. But what we'd really like to do is to get the fat back, not to make those of you with partial lipodystrophy fatter in the areas you've got fat to, but to bring the fat back where you don't have it. And some forms of lipodystrophy could be associated with death of cells. And so there's a group I know working on cell death to try and block death of adipocytes and that type of thing. So there is that type of research going on at the moment. And I think that's all. I'll stop there. Thanks very much.
Thank you, David. Does anybody have any questions?
Talk about fat cells. Talk about fat cells. So with people.
Yeah, you were talking about fat cells and people with lipodystrophy. Have they actually lost their fat cells, or are they just disabled in some way?
Yeah, it's quite difficult to figure out. If you take someone with generalized lipodystrophy, whereby any kind of scanning, there are no fat cells, and it's hard to know what to biopsy. But if you take a biopsy where you think fat should be, you sometimes do see a few little precursor cells there. So it's actually quite difficult to say for most of them whether probably there are little precursors of fat cells, but they're so dysfunctional, they're barely there, basically. I think that, but we don't know for certain about that.
So,
yeah.
So the treatments targeted at, if you talk about some possible treatment.
Yes, to try and rescue them. Yes, it will depend on the type. It will only help in some. Yes. Yeah. Yeah. Yeah, because in mice, you can actually transplant a certain amount of fat, and that's not all of it, but that's helpful. But fat tissue is poorly vascularized, the blood supply. It's not easy it's not like a liver transplant. It's not such a clearly defined organ where you can replace it because fat's all over. It's very dispersed and has quite fiddly blood supply. So it's not an easy organ to just transplant back.
Yeah. With the liver disease, is there much more research going into how long the liver will cope when it's constantly getting the fat on it?
So there's a lot of research into fatty liver disease. So fatty liver disease, not just in pretty much everyone with significant lipodystrophy has fatty liver disease, but fatty liver disease in general is affecting 10 to 20% of the population, mostly related to being overweight. And there are no licensed therapy specifically for it, other than just trying to lose weight. But that means there's a huge market. So there's a huge interest in trying to improve it. And yes, there are specific drugs in the pipeline. It's too early to say how effective they're going to be. But there is a lot of work in that area to try and understand it better. Yeah.
Hi, could I ask, so I
still suffer a lot with hunger, even though I have the Ozempic, and I'm at the highest amount that you can take. But with lipo or lipo, will that be more of an issue because of I have obviously the lipo as well? Whereas if I were just diabetic, would that help with the hunger? So I don't know if I'm making sense.
Sorry, I missed the first part. I heard you say that hunger is a particular problem, and then I missed the little bit after.
I just wondered if, because with the FPL, does that make it slightly harder with the hunger, and would that sort of dissipate more if it were just the diabetes? So when I speak with my insulin nurse, obviously sometimes I'm still hungry, and her response is, well, obviously that medication's supposed to stop that. And it has helped a lot, and I have lost weight with it, but I do still struggle a lot with hunger. And I wondered if that was a product of the lipodystrophy, or whether it was just me being hungry.
Yes, yes. So obviously there's kind of a big spectrum of how hungry people are in the general population. And then with lipodystrophy, you're going to add lipodystrophy on that general background. So there's going to be a spectrum within the lipodystrophy community of how hungry people feel, just because there's a spectrum in the general population anyway. But lipodystrophy itself, if you have generalized lipodystrophy, you don't really have any functioning fat cells, and so you don't produce this hormone leptin. And without leptin, you feel like you're starving. So in generalized lipodystrophy, it's a big problem. In partial lipodystrophy, you have a relative deficiency of leptin, and so you will tend to feel more hungry in general as a result of that. And so, yes, I think in general, it's harder for people with partial lipodystrophy to lose weight and feel less hungry. But it is still possible, basically. So, yeah, I don't give up. I think one just has to fight that battle. I think it's our clinic, that's why the dietitians are such a huge part. It is the most effective way to alleviate the diabetes, but we do appreciate that it's a huge challenge. Yeah. Yeah.
Hello. Could you tell me if lipodystrophy is actually a piggyback condition, the cause of other complications, or is it caused by other complications, and does it have a gene that triggers it?
Sorry, I missed the end part of that.
Does it have a gene that triggers lipodystrophy?
Yes, sorry. So it's not a piggyback condition, no. In the 20 or so genetic causes we know, it's the first abnormality, and then so it's the initiating problem. And then because your fat cells aren't working, you're more likely to become insulin resistant, get diabetes. Those things are all a consequence of the lipodystrophy. So it's an initiating problem. And yes, we think there are 15 to 20 different single genes, which of their own, if you inherit that genetic abnormality, you will get lipodystrophy almost certainly. So yes, there are lots of specific genetic changes that cause lipodystrophy. Yeah.
Hi, I just wanted to ask about, you've covered generalized and partial. I've been told that I've got progeroid lipodystrophy. Would you be able to explain that?
Yeah, explains quite a challenge, but tell you something about it. Yeah, so progeria for other people is a kind of early aging problem. And so there are certain genes that are associated with premature aging. So, you know, graying of the hair, wrinkling of the skin, that kind of thing. As well as lipodystrophy. So those are amongst the syndromes where there are quite a lot of other features in addition to the lipodystrophy. And there are a couple of different genes that have been linked to progeroid syndromes. And yes, so that's kind of where we are. The people with those have other features related specifically to the progeria as well as the lipodystrophy and its metabolic complications. Yeah, and we know quite a bit about the genes involved in that. Yeah.
Any other questions?
Hi, I know you mentioned that there's a study looking at the pathway of why the fat cells go into the liver and the muscles.
Yeah.
Would that also involve maybe looking at something to slim the muscles, bulk of it?
Oh.
Try and, you know, because...
Yes, no, not directly in that study. So some forms of lipodystrophy are specifically associated with muscle hypertrophy, which kind of overgrowth of the muscle, which particularly for women who are not athletes, that is unappealing to many women. And so that particular study will not change that directly, but there is an interest and research into what's causing the muscle hypertrophy enlargement. And if you could understand that properly, which we don't understand very well yet, but if you could, then you could try to reverse it. So not directly part of that study, but there is work going on into understanding it. Yeah.
Any other questions? No? Well, thank you. Thank you very much, David. So again, I think you'd agree that was very informative. Thank you very much, David. Now we've got a short refreshment break, well, half an hour. So take a time, have a comfort break, get something to drink, and we'll be back in here for 12 o'clock with Fabio, who's going to talk a little bit about appearance research and what's being done in that space. So thank you very much. So coming back and joining us again for the session before lunchtime. We've just got two talks before we have some lunch. First of all, we're going to hear from Fabio. Fabio, I don't know if you remember, I think it was 2020 when we did some videos for World Lipodystrophy Day on our YouTube channel. Fabio did one of those videos. So some of you may be familiar with him and his work, and he's going to talk to us about the psychology of living with an appearance affecting condition.
Thank you very much, Rebecca, and thank you everyone for being here. And it's been great to meet with you over dinner and other times, and really just getting to learn more about the condition or conditions really. So as Becky said, my name's Dr. Fabio Zucchelli. I'm a researcher, a psychologist, and lecturer based at UWE, so the University of West of England in Bristol, and based at somewhere called Centre for Appearance Research, or CAR for short. And just going to tell you a little bit about what we do and hopefully how that might tie into your own personal experiences, whether yourself or a loved one. And thinking ahead as well to potential for kind of working together at any potential future events that hopefully will happen, and the way that we might actually be able to do some research together to understand the experiences that might be unique to living with lipodystrophy. So just, yeah, to let you know that that's the kind of the context and what I'd be looking to do in the future, if there's enough interest. And it would also be understanding from you, what is it you really want to learn about the psychology of lipodystrophy. It's nice already to hear some stories or some ideas about the kinds of things, like fatigue and diet that are a pressing concern. Sorry, can you all hear me okay? I think I'm talking a bit far from the microphone, a bit too tall. So who are we at CAR? We are a group predominantly of research psychologists, backgrounds in health psychology, social psychology, and clinical psychology as well. We work with a range of different charities and organizations who are together called the Appearance Collective. So they're about 25 different organizations who support and represent people with a range of different conditions and injuries that affect appearance. And that's really the focus of this group of us that you can see in the photo there at CAR. We're led by Professor Diana Harcourt. Lasering her head, there she is. We've been running for about 30 years. So when I say visible difference or appearance affecting conditions, what do we mean by that? Because, you probably identify as having lipodystrophy rather than a visible difference. So it's a term that we use sort of, in academic literature, but also charities like Changing Faces, who support and represent people with any form of visible difference, a term that they use. So really refers to any appearance that is different from a culturally defined norm, which is visible to others. And I appreciate that that's not necessarily a very kind of black and white clear line. So it's really about the person's subjective experience. So different causes, it could affect any part of the body. It may not be visible during every interaction. And this goes across the wide range of causes of visible difference. So it could be congenital cause, such as cleft lip and or palate, which is the most common congenital facial difference. Could be something like Apert syndrome or microtia, where there's atypical development of different parts of the body. It could be acquired visible differences, so that could be through physical trauma like injuries or burns, scarring. That's Katie Piper, who runs the Katie Piper Foundation for Burns, which is one of the charities that we work with. Skin conditions, and these are probably kind of one of the most common causes of visible difference. And again, you know, saying they might not always be visible, they might sometimes be more visible than other times, come and go. So skin conditions like psoriasis, eczema, which are incredibly common, that, you know, particularly for some more than others, may be seen as a visible difference. And also medical treatments, for example, following treatment for head and neck cancer or other cancers, mastectomy from breast cancer being another example. And there are, of course, conditions that can either be acquired or congenital. One example being facial palsy, but lipodystrophy, or the cluster of lipodystrophies, clearly falls into that category as well. And I've actually just authored a paper where we found that on average, there's no difference in terms of the psychological impact from congenital versus acquired causes of visible differences. Clearly, there will be kind of unique differences, and, you know, when I talk about on average, I'm really thinking about at a population level rather than any one person's experience. Everyone's experience will be different, of course. So the prevalence of visible difference, Changing Faces, the charity I referred to, estimate that at least 1.3 million children, young people and adults across the UK have some form of significantly visible difference. And when they talk about a significantly visible difference as well, that's because that is the protected characteristic under which people are protected by the Equality Act. So that connects to employment law. So any kind of discrimination in the workplace, it's important for people to know that if they consider themselves to have a significant visible difference, which of course might be slightly problematic in legal terms because of its subjectivity, but you would, in theory, be protected by the law if you feel that you've been discriminated against due to the way that you look. So what we do at CAR, so our overall goal is to improve the lives of people affected by visible differences and their families and friends and loved ones, really by examining people's experiences, their subjective experiences of living with a visible difference, as well as societal attitudes about visible difference and how to actually change these when there seems like there is scope for change, more positive change, and ways of supporting individuals to adjust to a life with a visible difference. Some of the common methods that we use will be often actually speaking with people directly. So those might be things like one-to-one interviews or focus groups. Quite often we'll use more creative methods. So we might use things like asking people to bring in photos or engage with making videos. Young people might be more kind of play-based activities as a way of kind of generating discussion and using people's kind of real-life experiences. And a lot, as you're probably used to, you might get a lot of online surveys as well, some of which might have scales and other things like that to try and quantify people's experiences. I suppose with something like a rare condition, we might often lean more towards the more qualitative or more, spoken word approaches, because it's difficult to get the types of numbers that you might need to be able to make really clear scientific inferences from the findings. So, as I'm sure you're all aware, people's experiences of visible differences are multifaceted. There's lots of different ways in which people might be impacted, physical, social, and psychological. Now, there's very little, as far as I can see, in terms of research literature that's been carried out, research that's been done on the psychological, social experience of having lipodystrophy specifically. I can see that Dr. Anna Steers, who we've heard from before, was a co-author on this paper, which is based in Cambridge as well. And this was a qualitative, so interview-based study with a small group of people who have lipodystrophy, adults, I should say. So this is really a kind of rare or unique piece of work that's great to have as a stepping stone to understand people's quality of life, impact and experiences in relation to body image and appearance concerns. So physical challenges certainly can vary depending on the conditions. There may be pain, fatigue, which we've already heard about, reduced mobility, long-term treatment, managing all of the kind of health implications and going in and out of treatment. It sounds like as well, like lipodystrophy, the sort of uncertainty, difficult getting diagnosed correctly. There might be misdiagnosis, uncertain prognosis, and certainly other appearance affecting conditions share some of these challenges. But yeah, clearly there is more beyond physical challenges. So this is an excerpt from that article talking about one of the themes that came up from the interviews being there's more to lipodystrophy than managing symptoms. So it was felt that healthcare professionals focused on the medical management of the condition to a certain extent, and that there is much more beyond that. And we've heard Anna talking about and others talking about the kind of need for psychology input in healthcare services. So social factors that are common across the various different forms of visible differences, relationships, we all have them, and clearly appearance as well as the other factors can have an effect on relationships, how comfortable people feel in relationships. And I'll actually come on to this in a bit more detail in a moment. The overall pressure to look normal, inverted commas, and how that may be influenced, particularly by modern day culture and the advent of social media being such a kind of appearance dominated landscape. Social stigma, the idea of interaction sometimes being difficult, through whether it be ignorance or simply, rudeness or other people's issues, things like staring, comments, teasing, particularly at a younger age. These are all kind of common challenges that, the people with visible differences face, and ways of managing that being really something that people want. And as mentioned, social media, but clearly it can be used for good as well, particularly with rare conditions, when you can connect with others who share those conditions and be able to actually feel that sense of togetherness and community. But clearly there are more challenging parts to social media as well. Work and education. So I kind of talked about workplace discrimination, but more kind of general experiences which may be positive and negative. It's part of people's social world as well. But that idea of we obviously want people to feel that they're not being held back in their own personal aspirations, whether at work or education, because of the way that they look. That's kind of our main focus. Psychological impact. So I really don't want, a message I don't want to give is that it's all bad. Actually we've done interviews with people with ranges of different visible differences, who describe themselves as actually having adjusted really well. And so much comes out that we kind of hear about across different conditions, things like personal growth, improved resilience and perspective, and a sense of wisdom, and understanding, you know, who your real friends are and what really matters to you, and kind of almost being able to step back from some of the appearance norms and pressures and see through those things. So there's real strengths that people that often people with visible differences will gain, that I appreciate, you know, may be hard earned. So there's also an acknowledgement that for many people there may be some social anxiety and a tendency to kind of avoid social public situations, low mood, and more kind of general appearance concerns that might tie into you know, body image concerns that everyone has, you know, whether it be weight as well as other things. So this is an important point, really. So when we ask the question, what shapes how well people adjust? One thing that we know for sure across multiple studies is that the kind of objective degree of someone's visible difference. So, for example, how visible something is, someone's differences in a public setting with, you know, whilst wearing clothes, is a really bad predictor statistically of how well people feel within themselves. So this is meant to show you can have a real range of different appearances, and people will be living a, you know, really fulfilling life. And you might have people who actually look normal in the sense of the culturally presented term, and actually really struggle with appearance concerns. So that's a really important message, is that actually individual differences and personal outlook is a much bigger predictor of how we feel about ourselves than simply how we look. So often, for example, when people who have burn scarring, studies might use a kind of objective measure. So a doctor may actually look at the percentage of the body that is affected by burn scarring and use that as a measure. And then people would themselves describe how visible they think it is, so more of a subjective measure. So the subjective measure is always a better predictor than the objective measure. So that just shows us it's all about the own person's perspective and feelings. So what shapes how well people adjust? Again, good social support is really important. And that might look different for different people. So someone actually might need a lot of input from people and have lots of people around them. Other people might just need one or two really key people in their lives. And this might tie in with how introverted or extroverted we are as well. So it's not like one size fits all. We must be in a huge community of support. It's just whatever you need. Like, that's the important thing, that being met. Being active in coping. So it's very natural for many people, you know, if you're worried about how people might react or act around you in public or social settings, to avoid that. You know, sort of can be human nature. But we find that people who try and take a more active approach in coping with those difficulties, so for example by joining support groups, or even if it's, you know, taking up new hobbies or joining social groups, little and often, that tends to predict a better psychological well-being. Social acceptance, which is sort of subtly different to social support, because this is the idea that you feel generally accepted within your social circles. Optimism as well, which might seem like, well, you're kind of born with it or you're not, but actually it's something that people can develop. There's plenty of kind of self-help material out there and ways of developing a more optimistic outlook. And also, I mentioned this a little before, seeing through some of those appearance ideals, you know, that we're told in seeing more and more sort of things like phone filters, selfie filters, and the idea of what you're meant to look like is ever shifting. And actually, the more that we can step back and take a more kind of critical thinking approach about what we're told that we're meant to look like, the more people can do that, the less invested we are individually in how we're meant to look. Easier said than done, but again, there are things, there's plenty of kind of material online. A lot of it is around media literacy, social media literacy, just basically seeing behind the all of the work that goes on and the kind of corporate investment that goes into trying to make people feel bad about the way that they look. So the more that we can see that and see through that, the more people feel less kind of bound to those ideals. And this is just another quote from Adam's paper. So this is specifically looking at lipodystrophy. And one theme that came up was actually the kind of the sense of feeling accepted. They wrote that the benefits of meeting other people with lipodystrophy, either face-to-face or via online social media, was reported. It appeared to be a good source of support and understanding for many, and reduced feelings of isolation and loneliness. Sharing experiences and hearing about how others were getting on reassured people that they were not alone and that there were other people just like them. So basically, today, what you're doing here, just showing how wonderful this is and how important it can be. So stepping back to what we do at CAR, we have a kind of funded program of research that we're doing. And again, with our overall goal, the work that we do is currently split into two different programs. And an area that I work in is developing and testing support interventions, a lot of which will be sort of self-guided, because although we're research psychologists and we do work with clinical psychologists and other therapists, we're not clinicians. So we're not so much looking at, for example, clinical psychologists therapy with people. It's more about what could we put out there for people to use themselves that are kind of simple and usable and don't need a lot of intensive input, which clearly can be an issue when there are challenges with resources and number of psychologists available at any one time. The other area is social media and visible difference. So that's, again, looking at the good and the bad aspects and seeing how it can be used as well in a positive sense. And that relates really to this slightly awkward looking triangle. So with a view to improving people's lives, we could do that at different levels. So at the top, we're thinking about the kind of complex specialist-led therapy. So that might be, for example, a clinical psychologist embedded into a healthcare service, someone that you can actually speak with for an hour, over 8+ weeks, which clearly can be really important and perhaps has the kind of highest dosage, if you like. And then so that's at the individual level at the top. And then it might go down to something like, I think this laser's working. There's more kind of self-guided intervention or support. And then a standalone intervention. So just something that you can just use fully yourself that has been developed and is shown to work as an evidence base. And then at the society level, so the reason that this is the bottom of the triangle is because this is looking at the number of people who it can actually reach. So these more general population campaigns might be trying to develop awareness, for example, about lipodystrophy and other forms of visible differences, so that ultimately the hope would be we would reduce the kind of level of staring comments, often related to ignorance, that people have to encounter. And so generally raising awareness and also of kind of appearance pressures. And when I talked about being able to see through some of those appearance ideals, we've got the whole population to be doing that and thinking more critically about the way that people are made to feel about their bodies. So we do try and target this whole spectrum, really, because we appreciate that it's not just people with visible differences that, you know, just supporting people at that point is only doing part of the picture, because part of what the social challenges they face, you know, should need to be addressed as well. It's a kind of problem, more of a societal problem than an individual problem. So things that we've done at that level, at the societal level, an example of is a board game that we produced with a board game maker called Focus Games. It's a kind of educational, entertaining board game for children aged 9 and above. And its goal is to aim to promote the acceptance of diverse appearances. And that is quite broad, you know, because we're thinking about weight and shape, color, ethnicity, the range of different abilities. We've published a paper showing that has positive effects. So that's something that can actually be bought by schools, is available now, if it's something that you'd be interested in, or if you're an educator. And this is something that my colleague, Dr. Ella Guest, is continuing to work on, is using social media for good. So some of the kind of experimental studies that she and other colleagues have done. In this study, they looked at a skin condition called vitiligo, which can be quite sort of prominent as a visible difference, particularly in the summer months. And one finding from their research was that giving information about the causes of visible difference next to photos alone helped reduce stigma more than just the photo. So actually, for people to kind of understand more about the conditions and to maybe have more empathy and kind of awareness, actually information as well as just photos makes a bigger impact. I think the photos alone didn't really change people's levels of stigma. So just as an example, really, of the kind of seeds that we're sowing in this kind of research, we're also looking, I think, at the moment at social media influencers who have visible differences, who have, you know, people who follow them and they kind of almost have a voice online. And someone like Adam Pearson, who you may or may not have heard of, who was recently on MasterChef, is a really big campaigner for the charity Changing Faces, and he's just brilliant because he's funny, he's sort of, you know, he's smart, he's self-deprecating, and there are just so many people out there like that who we want to kind of learn from. How can these real inspirational people lead the way and show us how social media can make a positive impact? So looking towards the more individual ends, providing support for people individually, well, we've developed and tested tools that already exist. So some of these exist already, are available openly. Some of them we're working on now and developing and to test. So this one's already available. You can download it from our website. If you put in Centre for Appearance Research, it's on our resources page. So this is based on an existing body image intervention. Basically a set of writing exercise. So it comes from it's in the form of an editable ebook, focusing on what your body can do. So the theory behind it is a positive body image. So functionality. So the idea of what our bodies can do versus what they look like. That's the kind of the reframing that it focuses on. And also reflecting through these writing exercises, what these functions mean to you. I think it's important here to say that it's not dismissing the fact of how important appearance is, nor that there are lots of physical challenges that come with conditions such as lipodystrophy. I suppose it's more building on the basis, and it's very easy to say this as someone who doesn't have a kind of long-term health condition, but the principle of there being more right with you than wrong with you if you're alive and breathing. So it sort of builds on that perspective. And so the more that we're focusing on the things that our body can do, whether it be sleeping, You know, the kind of list is almost endless. And the more that we focus on what's right with us than what's wrong with us, the more we start to have this kind of positive, almost optimistic outlook. So these are just the kind of the categorized examples that are given in the ebook. So body functions related to physical capacity, so things like flexibility, coordination, yoga, etc. And then those that related to relationships and communication, so talking, hugging, shaking hands, laughing, all of it, you know, when you start to break it down, what our body's actually doing through these social processes, it, you know, can maybe help in some way. So that's one, which I should say has been tested through a randomized control trial and shown to have positive effects. So this is something that has been developed and we're looking to test very soon. So if you're interested in potentially being a participant, you could contact my colleague, Maya Thornton. So this is off the back of some research that she and a colleague, Nick Sharrett, did, looking at intimacy in close relationships, romantic relationships, as a challenge that many people with different forms of visible differences told us about. So we kind of wanted to hone in and produce something that looks specifically at that challenge. So this is done in the form of a podcast series, and its goal is to really help people manage as well as thrive in close relationships. It's based on an evidence-based form of psychological therapy called acceptance and commitment therapy. And it's coming very soon. We have ethics approval to start the study. So as I said, if it's something that you'd be interested in, Maya Thornton is the person to go to. Obviously, if you spoke with me, I could get you in touch with her too. In terms of what's already available, we have an online web-based program called Face It at Home that people, so this is for adults, I should say. It's an 8-week self-guided course. This is based on cognitive behavioral therapy, as well as social skills training. It's accessible, as far as I'm aware, through the charity Changing Faces. So I think they would provide you with a login to be able to use it. There's also YP Face It, so an adapted version for young people for 12 to 17-year-olds, which is an online 7-week self-guided course, using exactly the same principles, but that had been adapted to make it more kind of usable for young people. And that can also be supervised by parents as well, so you have a separate login. And again, this both of these Face It and YP Face It have been shown in randomized controlled trials to be effective. This is what I'm currently working on. This is a bit like the gentleman noted earlier. Often nowadays people expect to use self-guided programs on their phones and, you know, make use of things like notifications and being able to plug in to listen to guided mindfulness exercises in the case of this program that I'm developing. So yeah, I've over the course of about 4 years now really went from the left scribblings layer to wireframe to a prototype that was very kind of easy to make, and now we actually have funding to work with an app developer to build it. And they are expensive. I think often you'd be looking between sort of 40 and 80,000 pounds to get to a minimally viable product. So that's definitely kind of a concern, is to make sure that we could actually sustain it going forward. But it's a kind of a condensed version. So it's based on acceptance and commitment therapy, hence why it's called Acted Out. And it's shorter, so 6 sessions, everything's a little bit more bite size. You'd kind of monitor things as you went along. It's a bit more interactive. So we're currently developing this. It might be about 6 months or so to develop it. And again, we would then look to actually test whether it works. So again, coming soon. Also, we have my colleague Maya Thornton again has developed, as part of her PhD, a package which is a toolkit for parents of children with any form of appearance affecting condition or injury. So this again is an editable ebook, and this is actually open for research very soon as well. So again, if you would like to participate as a parent of someone with a visible difference, then you may well be eligible to take part. So yeah, that's really, you can see there's quite a few different kind of programs that we have developed based on the evidence that are either out there for you to use already, or that you could be involved in as a research participant at least. If you want to find out any more about our work or be involved, I should say I've just left some cards on this table and on the one over there as well, where you could sign up to be a member of our participant pool. So that's a pool of people who've registered interest in taking part in our research. So if we do any research studies that you would be eligible for, we would then reach out to you and invite you to take part. So obviously you'd never be kind of asked to take part in something that wouldn't be right for you. And also everything is fully voluntary. So you're never signing up to anything. And even when you start research with us, you can always just withdraw at any point you want. But you can follow us on social media. We also have a podcast that might give a nice sort of flavor of all the different types of research that we do, called Appearance Matters, the podcast. And there's some direct contacts for our research directors as well. But as mentioned, I think hopefully that's given a little bit of background about what we do and what's out there, what's available and what's coming soon. But also, you are the experts in your condition and the psychology of your condition as well. So in the future, I would, in principle, really like to actually do some direct research kind of with you at somewhere like this, when it's very rare, I imagine, for everyone to be together in the same place. So that's something that I would be bearing in mind. So yeah, open up to any questions or feedback or comments.
Thank you very much, Fabio. Just to let you know that Lipodystrophy UK are actively working with Fabio and his team as part of the Appearance Collective, and we will continue to do so on your behalf, and we'll be sharing links and resources, etc. We ran a little bit over, so we've got time maybe for 1 or 2 questions.
My fault, sorry. That felt like 20 minutes, but it was 40. Wow.
Well, it's all very interesting stuff. So anybody brave enough? No? Okay, that's
I'll
fine.
be around anyway.
So thank you very much to Fabio. Next, we've got Ekaterina, who's going to speak to us today. She is a clinician, formerly based in Russia and is now in the UK. And she's going to talk to us about the ECLIP registry that was mentioned earlier in the day.
Thank you, Rebecca. Thank you, Lipodystrophy UK, for inviting me. That really means a lot for me. I would like to apologize straight away for my accent, as English is not my native language, obviously. So, thinking about international cooperation, it's very important in medicine in general, but of course for rare diseases, it's crucial. There's even in brilliant teams, there's very limited amount of data you can gather, very limited amount of things you can do. However, when you all cooperate as professionals and as patients, that makes a difference. And so I stole the picture from Spanish Patients Society, which is great, by the way. Like I'm sure you have many good friends there. To be honest, I don't have too many conflicts of interest to declare at this session, but I would like to tell a little bit of my personal story and that of my patients, and you may maybe compare it to your story and experience living with lipodystrophy. So when I started my training in internal medicine and in endocrinology in Moscow, in a very nice place in like close to Moscow city center. That's not the clinic, that's the church right next to it. The clinic building is ugly, unfortunately. But we like lipodystrophy syndromes is not something which is immediately in the curriculum. So like you deal a lot with patients with diabetes, with patients with all sort of different chronic conditions. And then my colleague told me, oh, like, you know what, there's a patient with lipodystrophy and one of our consultants going to see it. You know, how exciting, how interesting. And like we all were like, okay, Google what's lipodystrophy. But then we actually never got to see that particular patient, but like we read something about it. Then there was a lecture about lipodystrophy is associated with HIV and antiretroviral therapy because that's more common. But then I had a patient in hospital admitted with like a lovely young lady, and now I guess I can say my friend, but because we've been in touch for more than 10 years. But back then, so like a lovely young lady who, and before going to see her in the ward, I see through her medical documents, and I can't quite figure out what I'm going to see now, because like 19-year-old lady, you automatically think, okay, type 1 diabetes, probably, like very high blood sugar. And then I see through her notes from before that in some notes it's type 1, in some notes it's type 2, it's really high reduction of her own insulin level. However, it's extremely high doses of insulin prescribed to her. It's also high blood pressure, which is unusual for somebody that young, and her body mass and body mass index is not like is normal, and also some other signs like protein in urine, in large liver, which is like not something you would expect to see in such a young person, and also some skin changes. So what I did, like we had, I think that day I stayed in clinic till like very late, and we had very long conversation with these patients and was trying to figure out what's going on. And I asked her if somebody in her family had anything, and like she told me about a few relatives with diabetes. And then I was like, okay, but like, you know, was there, if you think whom you look like, was there somebody? And then turned out she had quite large family with many cousins. And so she could then, when thinking about it, point out some relatives who looked a bit like her in terms of body shape, and also had either diabetes or some fertility issues or high blood pressure. So I was like, you know, investigating this case, which was like new for me and exciting, and like together with her, and I asked her to show me her family photos. I'm sure some of you might have been asked by your doctors to do that, and her photos from before to see at what point actually the appearance has changed, and also the photos of her relatives. And what and she showed me like the picture of her as a child, and one of the pictures was at the wedding of her auntie, and what I saw was that like her auntie at the like in her 20s looked quite similar to her. And so started to thinking about it, obviously thought that it should be something inherited, and starting to look up information. And then what happened, like I approached different consultants and professors in my department, whoever I could approach in Moscow, and yeah, the best like answer I was given, like, yeah, like it looks like that should be, but you know, we have no experience with that. We don't really know. We don't have funding to do genetic tests right away. So what did I do? I at the European conference that year, where I was like lucky enough to go with the poster presentation, I asked everyone if somebody knows about lipodystrophy syndromes, and then I got an email address of David Savage, who spoke before, and I sent him an email asking details and like having consultations like that. And so here, the international cooperation for me began the moment I got my first patient with rare disease. And both interested in that. So, and then the time came where I was offered to like, if I want to apply and like do some research. And I was, to be honest, like I was not initially that type of person to necessarily do the research. I wanted to do clinical work and help the patients, because that for me gives like much more reward, immediate reward, because with research you need to wait ages. But then I thought, okay, if so, then like let's try. Like I want to study lipodystrophy syndromes, because obviously in Moscow and in Russia, we're like definitely underdeveloped with that. We should have patients. Well, I had at that moment only one family, but I was certain that there should be more out there. We need to find them among the patients with diabetes and other umbrella syndromes. So let's then try to do that and find funding for that. And so yes, it started to do that, and like was basically one way or another doing it throughout all my career in Moscow. And that felt very rewarding, although I feel now ashamed showing this, because David knows the genetic cause of 90% of patients. I still don't know genetic cause in 90% of my former patients in Russia. But I felt very happy, because it was less of fortune telling and like more of understanding what's happening with the patients. And we got to like diagnose many new patients who never had the diagnosis of lipodystrophy syndrome before. But what I found out when working with patients is that very often the doctor's perspective of what's happening is entirely different of the patient's perspective. Because I was always like, okay, like, so here's like all your symptoms, here's all your lab tests. That's really bad. That's really bad. That's something, okay, you can live with. So let's first focus this, and that. And then what I was hearing back was sometimes where it was like, okay, stop. This is not like what's bothering me right now at all. It's something entirely different. So with genetic testing, for example, so like, you know, doctors, clinicians really wanted for diagnosis. Of course, they wanted to be like to have that option. So for it to be affordable, they want to use it to predict complications and something what's going to happen with the patient. And ideally, they want to understand like mode of inheritance if there is a diagnosis, and best treatment options. For patients, sometimes this genetic diagnosis comes as a shock, and sometimes it raises even more questions than there were before. And so like, but on the other hand, sometimes it's a relief. So we're going to talk about it a bit later. So for example, as you by now know, or just can tell looking at each other, lipodystrophy syndromes are extremely variable. And sometimes, so a lot of things depend on what exact gene is affected, what exact gene mutation, but even within one mutation, there might be big variability, and people who have on paper the same diagnosis might even look very different, might even happen in the same family. So when I was getting the results, I was thinking all those medical problems, and then my patients were thinking different things. So, for example, one of the girls with whom I was very concerned is because it's a typical progeroid syndrome. She was only concerned about her swimming and performance in there. And the other girl with also very severe form associated with some progeroid syndrome symptoms. She only wanted normal school life and like actually society be more acceptable of her appearance and her condition, and to be able to eat tasty food, to look beautiful and things like that. And some patients, unfortunately, like they lost track quite quickly because they were like, okay, you found that out, you can use it for your science, but I don't want to hear anything about it. Diabetes is something everyone has. That's something I don't want to be like referred as like some or freak with something nobody has. So just, you can keep it for your record, but I'm like not going to see you back. And some patients were not like that easy to persuade. They were like, what's that? Well, okay, give me your conclusion and then these results, and I'll go do some search myself on the internet and I'll think about it. Now see, and in these situations, resources like Lipodystrophy UK and our patient-oriented resources are very helpful, very good, because then they would come back and say, okay, actually, yeah, I did. You might be right. There might be like something about me in that. So. So like I said, sometimes this diagnosis and genetic diagnosis is the burden for the patients, but late diagnosis and late understanding of what's happening is so much more of a burden usually, at least from like medical point of view. So one story is that of actually the auntie whom I showed before, who was only discovered and diagnosed through her niece, who went to our clinic so late when she was 59. And by that point, she had the whole story of like early, both physical appearances problems and medical problems, like very early diabetes, early for a woman myocardial infarctions, many problems which unfortunately like have already happened, and it's like can't be reversed, can be helped, but so much more could have been done if she was diagnosed earlier. The other story is that of a patient with actually congenital generalized lipodystrophy, which is rare to be diagnosed in an adult. Usually it's like spotted in a child because it is a different appearance, and usually some doctor in Russia, there is no GPs, so kids are followed up by pediatrician. So normally pediatrician would like pay attention to that, but that particular patient as a child was falsely diagnosed as acromegaly, and only pure chance that something has happened and her surgery couldn't have happened, like saved her from brain surgery unnecessary, because the treatment for acromegaly is like surgery on basically brain surgery. So, and then throughout her life, she kept hearing that she must have acromegaly whenever she was anywhere near medical institution. And again, type 1 diabetes or type 2 diabetes, or maybe anorexia, and she's faking this thin appearance and lack of fat, or maybe she's secretly working out all the time and just, yeah. So when she finally got her diagnosis in her late 30s, that was a relief for her. And then patients with acquired lipodystrophy, or what at that moment we like put in this basket because we don't know more. There are some acquired forms which can be well explained, but others, they're just like, they're there because we didn't find any genetic cause. And then in those cases, me as a doctor, I always feel like I could have done better, but I already did this, and that, and everything. But like still, I don't fully understand what's happening with the patient. But what I found out that patients actually, when I tell them, okay, we did all possible genetic tests, and I still, so like you should have it acquired like alongside this other condition which you have, although like it wasn't previously reported to be associated with lipodystrophy. So I don't know. They actually, oh, that's good. That's good news, doctor. Great. I don't want to have some genetic mutation and then, so it's good. Let's just leave it there. I don't have it. Great. So better like this. So, and then one of the patients like that is actually that very first patient who was seen by another consultant when I was a resident. She like then came back to me when I was a consultant, and I'm still not quite sure what's happening with her. She's very complicated. So, but when I started to do study, that's when I really joined the international cooperation and ECLIP, which David mentioned before, European Consortium of Lipodystrophy. is actually, I think, the greatest international group of doctors and scientists cooperating. Because, well, I don't know if you have a lot of experience of scientific meetings and organizations, and it's usually mostly it's like huge, very fancy, boring talks for ages, and nobody really like cares that much about other people's data, and just like, you know, want to like, it's a step of like, you know, establishing that you did a good job to like give a talk at such things. But Eclipse, nothing like that. It's really like a family of medical professionals interested in lipodystrophy, and also cooperating closely to patients' organizations. And as a result, but you may think like, okay, that was interesting for you as a doctor, as a researcher, what's in there for the patients you've been taking care of? But turned out that like it improved their access to treatments as well, because thanks to that, like I was going to those events, was saying like, oh, we have this many patients now, 100 patients now, and like, you know, there's no treatment in Russia. And eventually all those like foreign companies producing treatments got interested, and then clinical trials went in Russia, and Russian patients participated in those trials. And eventually more or less like metroleptin became partially available. So, and of course, guidelines are very difficult in rare conditions, but if at all possible, only with international cooperation. And so now at the moment, I want to show this so you can compare. I'm not yet 100% sure what's your situation with access to special treatments, rare treatments, but in Russia, it was so like 12 years ago, I like started to attempt to like find out how, if patients need special treatment like metroleptin, how can they get it if it's not registered in the country, if it's produced by an American company, which is not, there was a period of time when it was some company who had representative in Russia that seemed doable, but then shortly it became a different company who at all didn't have an office even. So, and it was all like very difficult, but then eventually they got the distributor in Russia. And so since then there was some movement, and so it's at the moment different for children and adults. So for children, there's a charity foundation. It's a state law charity. It's like some part of the taxes go to this charity. So it's not really charity, right? Because charity, but okay. So like taxes go to that charity, and that's like charity for treating all rare diseases in children. So and there they like they required, in order to include lipodystrophy in that, they required very strict criteria to whom they can provide the treatment. And I was like, well, but you see, it's such a disease with all different forms, and not like that. They're like, no, like if you're doing it like this, we're not giving the money to buy the treatment to anyone. So please, very strict criteria. And so I tried my best to make criteria like somewhat that looks formal for them, but still like which might include all children who need the treatment. So at the moment it's like that, and 3 children are already receiving metroleptin, and 3 adults are like close to receiving it. They already have all legal paperwork, because for adults it's totally different. There's no foundation that's like through like our version of NHS, and so basically adults go through trials. So like every adult who's been prescribed metroleptin will have a trial with the Ministry of Healthcare proving that they actually need it, and they will get it. 1 adult has received metroleptin like that, but unfortunately, like already she's like not with us. But yes, still metroleptin is not registered in Russia, but there is still 1 clinical trial ongoing of a similar product. Actually, I don't know if there will be more. I hope there will be. Yeah, so for Russian patients, as you see, it's not very like easy either. But another initiative which is very good and international is a CLIP registry board, or a CLIP registry which has a board, and Rebecca is the member of that board as well. So and I think it's really good that it's not only, because obviously most of the stuff is done by medical professionals, like the data is entered, but in the end of the day, that's all for you guys. So there should be an active representative for you. I appreciate Rebecca is very active and outstanding person, but maybe she cannot forever do all activities. So at some point, like the board is changed every like 3 years or so. So at some point, you know, maybe consider somebody should help Rebecca with something. But yeah, so like everyone's who's like in the country is covered by a registry, I think like can volunteer if they want to join. And so at the moment at the registry, just to illustrate for you how important the registry is, so like at the moment there's about 600 patients data entered. Well, it's not, and because I'm one of the physicians entering this data, I know that like, yeah, the data won't be like, it's very time consuming, and so like it's not exact, it does not represent the amount of data that doctors actually have and have right to enter. It will be much less, but still, so almost 600, and that's without Cambridge, because Cambridge hasn't yet entered any data. They just, like they join, but they're going, and without some other centers who, because of bureaucracy, take long time to enter. Yeah, and yeah, although it's European, it's not exclusively like, you know, within European Union or even European geographical borders. It's open to like anyone who wants to join. And I would like to thank you for your attention, and thank Lipodystrophy UK for inviting me. That's in the corner one of my patients, and her Instagram, I don't know if it's grammatically perfectly correct, but I like the spirit that if you dream about something, you can do it.
Thank you very much. That was really interesting, and it's great to have you here and advocating for patients. Have we got any questions? No, nobody?
Thank you.
Thank you very much. So now we've got lunch, which I'm sure you're all really excited about, because I know I am. We've got an hour and a half. So talks will commence at 2:30. Lunch is a 2-course hot buffet. Those of you who stayed overnight and had breakfast, I think it's in the same place where we had breakfast this morning. If you weren't here last night, go out of the main entrance, and immediately across the road is in that building. You go in through the doors and it's straight ahead, and then there's signposts. So please go ahead if you want to go and have a lie down or, you know, a walk. Good afternoon, everyone. I hope you've enjoyed your lunch break and a chance to decompress after this morning's sessions. We've got a fantastic program for you this afternoon. Some of it's a bit lighter, you'd be pleased to know. We've got, first of all, we're starting off with the specialist dietitians that work in the service in Edinburgh, so hopefully some of you will know them, Catherine and Lisa, and I'm going to let them carry on. So, yeah.
Thank you. I'm going to assume all that clapping was for us and not just for Becky again, because obviously we know all of the dietitians more than anybody else in the team. So I'm Lisa, I'm one of the specialist dietitians, and Catherine over here as well. So we're both we've got about 20 minutes just to chat to you this afternoon. So we're both dietitians working at the insulin resistance service in Cambridge. So we're hoping that most of you will have met sort of one or both of us at some point. And if you haven't already, then we'd love to meet you in the future. So do get in touch with us. So today we're just going to talk about
a few different things. So we thought we'd kind of go back to basics a little bit, which I think David Savage did sort of cover a little bit of what we were going to talk about, but just sort of re-emphasize why diet's so important with lipodystrophy, because I think sometimes you're all working so hard making all of these dietary changes and really, you know, doing everything you can, and sometimes we sort of forget why that is. And we've got a lot of sort of friends and relatives who are here today as well, which is great to see all the support that you've got around you, but also just so that they understand. So when you're saying to them, oh, I have to have a low fat diet, I have to have a healthy diet, we just wanted to really recap for them as well why that's important and why they're asking for support with that. So we'll go a little bit into what the main dietary advice and things are, and then just a little bit about sort of food swaps, looking at food labels, a little bit about eating out, and then touch upon things like exercise, and then a few minutes at the end just for a little bit of discussion and any questions from you. So as I say, we've only got a few minutes, and we could honestly have talked all day about different aspects of diet. So we're not allowed to do that, obviously, because I think people would start leaving, but do bear with us. If we don't mention some of the most important things that you really wanted to know, then just get in touch with us afterwards, so we're happy to go through it then. The other thing, so when you were all coming in, and you've hopefully seen in your bags, we gave you all a piece of paper, and we've asked you if you could please put on there just one or two or three, if you've got loads of different things, but any of your top tips for how you actually cope with the challenges of following a restricted diet in day-to-day life, because we know it's so difficult and everyone says how difficult it is, but actually you're all doing it, and you're all going to have certain things that you found, maybe a product or something that's really good that you found would be helpful, and we'd like to be able to sort of compile a list of all of those top tips to share with the group, and hope that maybe Lipodystrophy UK could put that on their website, because if everyone here just gives one tip, then actually we'd have sort of up to 100 different diet tips for the people who are actually out there sort of doing all of this advice. So if you haven't done it already, it'd be really great if you could put something down. We've just got a box over there in the corner on that table, so just shove it in there for you, and then we'll get those all out to you at some point. Okay, so as I say, we're just going to go a little bit back to our basics for what we were doing. So fat essentially is just a nutrient, and it has lots of purposes. So we sort of heard a little bit earlier in terms of appearance. Fat's important in terms of appearance. It's their importance for comfort. So some of you are probably thinking these chairs are very bony with not having fat, but also fat is sort of a nutrient and used for energy, and it's in the form of these triglycerides. So you probably hear us talking about triglycerides when you get your blood test taken. So normally what would happen in someone who doesn't have lipodystrophy is when we eat those foods containing fat, it be in the form of triglycerides. If those triglycerides aren't needed for energy, then they go off to those adipocytes or the fat cells for storage. And there they remain until actually the body needs them. So if people are fasting or they're going to do something that requires more energy, then those triglycerides are released back in order to get the energy again. Unfortunately, with lipodystrophy, as you'll sort of be aware, those fat cells just aren't working properly, might not be present, and they're not available. So what can happen is when we're eating those foods containing fat, rather than the fat going into those adipocytes or the fat cells to be stored, actually that's not happening. So the body has to try and find somewhere else to store that instead. And as we heard from David earlier, the body unfortunately chooses to put them in things like the liver, in the pancreas, in the muscles. And we call this ectopic fat. So you might have heard that term being used before. Okay, so unfortunately, having the fat in the wrong place in the liver and muscle and pancreas, that's what leads to the insulin resistance, and hence our service being the insulin resistance, severe insulin resistance clinic. So the insulin resistance, insulin is a hormone controlling sort of breakdown of glucose and storage in the body. And in insulin resistance, the body makes more insulin to do the same job, and this causes problems. So some of the things that some of you will be experiencing to do with that sort of excess insulin and the insulin resistance. And we talked a little bit about those things earlier. So we want to prevent this from happening, and the best way in order to prevent this is actually through diet. So diet is the main treatment for insulin resistance and lipodystrophy. So we borrowed these slides from one of our registrars before because they seemed quite effective for a way of sort of describing that. So you can see if we think of it being sort of a capacity issue. So normally someone would have sort of a big fuel tank, and actually you could put lots of fuel into that fuel tank without causing any problems. In lipodystrophy, unfortunately, that fuel tank is a lot smaller, so any extra energy that's going into it is spilling out into those places it shouldn't be. So what we need to have in order to sort of control that spillage is to actually restrict the energy going in, and therefore those problems are going to occur. So that's what we're looking at in terms of the diet. We can change how much energy is going in. It's not easy to change how much energy is going to be in. I think you're all very well aware that actually when you're really hungry and there's lots of temptation around, that changing the amount of energy and having a sort of restricted diet is really difficult, but that's what we're sort of looking for in order to reduce those complications that we talked about before. So our main sort of advice is a low fat, low energy diet, and then increasing energy expenditure to help use up those triglycerides as well. We can look at sort of different drug therapies, which we talked about earlier on, and there is things like metabolic surgery that are all sort of future things that you can have a look at as well and chat to us about in clinic. But we thought today we'd just focus purely sort of on the diet side, because even if you're going to be using any of these other therapies, it all needs to be on top of a modified diet, not instead of a modified diet. So this is a bit of a wordy slide, sorry. So this is our kind of summary of what we're encouraging. So as you'll probably be aware, is our general advice is that calorie and fat restriction. So the leaner people can be, the less fat that's stored, there's less risk of all of those complications that we saw earlier. So we're aiming for a low fat diet. So we can use different ways to say what a low fat diet would be, but we generally say less than 20 to 30% energy from fat. And everyone looks at us and says, well, I don't know what 20 to 30% energy from fat is. So to make it a little bit simpler, we generally say that we should be aiming for less than about 10 or 15 grams of fat per meal. And our next slide shows a few sort of foods and how much fat is in them. And the reason we give an amount per meal rather than saying I'll have about 40 or 50 grams a day is that if we sort of say 40 to 50 grams per day, people sort of store up that fat and have it all in one big meal at the end of the day. And unfortunately that can lead to problems because that fat all going in at one point can kind of overwhelm the system, whereas spreading it out throughout the day means that your body can cope with that a lot more easily. So we encourage low fat choices using reduced fat cooking methods, sort of choosing sort of whole grain carbohydrates, so not things that are high in sort of refined sugar, having lots of vegetables. We know hunger, it's already been mentioned a few times, is a really big thing. So we know things like lean protein foods do help fill us up as well. And then one thing we really wanted to highlight was about healthy eating guidelines and cardioprotective diet advice, because unfortunately, actually a lot of this advice isn't appropriate for people with lipodystrophy. So in cardioprotective guidelines, the guidelines are about the benefits of increasing unsaturated fats. But actually for people with lipodystrophy, we kind of group all fat as being bad fat. So there isn't really a really good healthy fat to eat with lipodystrophy. All fat is sort of not encouraged fat. And I'll show you some of those different fats in a minute. But all the advice that we give, so all of these numbers and things, we would like to tailor it to you. You've all got a different type of lipodystrophy. You've all got different complications from lipodystrophy. All your blood results will be different and you're all on different medications to start with. So we sort of try and tailor it to you as an individual and go through kind of what's most appropriate for you. Okay, so as I said, these are some different fats that are in food. So things like avocados, things like olive oils, things like nuts, nuts, peanut butter. They're all things that if you read sort of healthy guidelines or heart protective guidelines, are all encouraging us to eat those foods. And it's one of the things we often say over in clinic quite a lot, is actually those foods are not the best choices either, because as you can see, actually avocado, about 20 grams of fat. So just by having sort of that in your diet, you're already significantly increasing your fat intake. I think people are fairly happy if we said, what's a high fat food? Everyone will say things like muffins or butter or cheese, and that's absolutely right. But we just wanted to highlight those other sources of fat that are maybe, it's not that people don't know they're full of fat, it's just because they're seen as being those good healthy foods. So we just wanted to make you aware today that those are still sort of not sort of good things to be trying to increase. So one of the things we look at is we don't want everyone to have to cut out everything they love in the diet, but actually there are better options for a lot of those high fat foods. So instead of cooking in things like oil, using the 1 calorie sprays, or using sort of non-stick pans, choosing the sort of white fish options or white meats rather than sort of oily fish, or red meats can significantly reduce the fat content. In terms of snacks, things like nuts and crisps are quite high in fat. Things like sort of air popcorn or pretzels are quite a lot lower. And things like cutting fat off meat, or choosing things like, you can see the bacon medallions. Everyone always says how much they love bacon. So, you know, choosing those medallions, getting rid of the fat, but still having a food that you enjoy in there. We've got the Eat Lean cheese, which quite a few people sort of enjoy, which is less than 3% fat cheese. So again, sort of not a bad option if it's something that you sort of miss or sort of disappointed to not have. And then at the bottom there, the one on the right is a 0% fat creme fraiche. So they're claiming to be the only company, Yeo Valley, that produce a 0% fat creme fraiche, but worth a try if you're someone that likes to have cream or something on food. So just a few little suggestions there, but what we're hoping is that the tips that you put in the box for us are going to be the tips from you that you're doing, and you'll say these are foods that are low fat and we really enjoy them, rather than what we've decided. Everyone we work with thinks Catherine and I have obscure food tastes, because we enjoy these sorts of things, but when we put them out for the office to enjoy, they don't quite agree with us. But that's why we need your tips for what you enjoy as well. So the other thing, so as well as fat, we do sort of look at carbohydrates with that insulin resistance. So what we're encouraging to do is to avoid sort of processed refined carbohydrates, so things like white breads or white cereals, white pastas, and trying to choose those whole grain versions where possible, which has the added benefit that whole grains are good for your heart as well. So it's good to try and have those as well as for the insulin resistance side of things. So encourage not to double up on carbs. And by that we mean if you're having pasta, try not to have sort of garlic bread on the side, that sort of thing, so that you're just having one source of carbohydrate in your meal, and just think about the portion sizes of them. You might have heard of sort of the glycemic index, so the measure of how quickly carbohydrates are digested. So we're looking for those lower glycemic index foods, the ones that are digested more slowly, release glucose more slowly, and that can keep your blood glucose levels more stable. So those of you who are using kind of continuous glucose monitors, you might see that after eating sort of refined carbohydrates, your blood sugars go quite high and then come down again. And we know in insulin resistance, you might be more prone to having a hypo if you're eating those higher glycemic index foods, because the blood sugar goes really high, your body overcompensates with the insulin, and then it can drop down low. So if you are seeing those patterns when you are checking your blood sugars, it's worth thinking again about trying to choose those lower glycemic options. Okay, and so this is just kind of an example of a meal that's maybe a bit high in fat, and actually a few suggestions for ways you can make that low in fat without hopefully having to sort of change it too significantly. So this is just a spaghetti bolognese made with 15% fat meat. And actually per portion would be about 22 grams of fat. If you swap that into the 5% fat meat and choosing the whole wheat spaghetti, not that it makes a difference in the fat but it's just, you know, that lower glycemic index food. And actually that goes down to just 6 grams of fat per portion. Or some people like the vegetarian options. So things like corn and tofu are much lower in fat. So just 3 grams of fat per portion if you swap from normal beef mince to corn mince, or turkey mince, it's only 1.5 grams of fat per portion. Or sometimes people like to sort of add beans or lentils and things to that. So maybe having half mince and half lentils or beans. And again, it significantly reduces the fat, makes it a cheaper option, and also has that fibre in there as well. So, you know, just things like that. And then instead of having one meal, you've actually got 4 different meals, because sometimes people say when they're following a healthy diet, there's not as much they can eat. They sort of struggle with finding foods. But actually, we're hoping this illustration just shows that actually instead of one high-fat meal, there's 4 different really nice alternatives there. So the British Heart Foundation on their website and Diabetes UK both have some really good recipe swap ideas, and you can put in that you need low-fat recipes and things, and they'll come up with some suggestions for you. So just a resource to have a little look at. So I'm just going to pass on to Catherine, who's going to go through a little bit more about sort of looking at labels.
Don't feel like a proper dietitian because I haven't got a strawberry on my top. Yeah. So I'm Catherine, I'm one of the other dietitians. So I'm just going to talk through a little bit about food labelling and then a little bit about alcohol and exercise. So just to start off with food labels, so a lot of the food that we buy is obviously has labels on it, and they legally have to write on there all of the nutritional information. So it's a great place to have a little look, but it's not always the clearest. So they have to write on the front grams of fat, saturated fat, sugars and salts, and the total amount of calories. And this is based on the reference intake. So that's, unfortunately, it's the same. They put it down as 2,000 calories for the whole population, similar with fat and sugars. They put it down for the same for everybody, and that's obviously not the case. On here, we've got number 1 would be your calories, and then you've got your fat on there, and then sugar, and then salt. But it's often better to turn it over and have a look per 100 grams. I think I might be being cynical, but I think a lot of companies are quite good at trying to skew it a little bit, you know, per 30-gram serving or per 20-gram serving. And then when actually you measure that out and look at how much it is, how many people actually have that serving. Also, some will include things like once it's cooked or not cooked. So again, weights are really different. So if you just have a little look and have a look per 100 grams, it's much easier to compare like for like. So if you pick up 2 jars of pasta sauce or 2 packets of crisps or something like that, you can have a little look and see how much it is per 100 grams. We've got some of these food label information sheets out there. We've got, I think, I'm not sure if you said, Lisa, we've got lots of information sheets out on the tables outside that you're welcome to take. But if you're aiming for the healthier choice, the low fat at the top, so it's less than 3 grams of fat per 100 grams would be a great place to start. If you're picking up and looking at 2 different products and it doesn't come as low as that, then it's going for the lower of the 2. So, you know, you can only do your best if you're out and about and you need to buy yourself a sandwich or a snack or whatever. You just need to, you know, try and make the better choice if you can. So the other thing we see with food labeling is sometimes it's really confusing. Often you see things like vegan or plant-based, and you think automatically that must be the better option. As you can see on here, it's not always. Sometimes there's an awful lot more fat put into some of the vegan products or the vegetarian products. So it's worth just having a little look. And then some of the health claims that are put on there, we were sort of saying earlier about, you can get, you know, Cadbury's chocolate is a great source of calcium, so it kind of draws your eye, or I don't know, that I'm trying to think, certain things like whole grain, you know, says contains whole grain, but they're really sugary cereals. So marshmallows, fat-free, but, you know, they're 90% sugar. So it's just being, you know, they can be a little bit clever with the food labeling. So it's just having a little look there and turning them around and have a bit more look in detail. So restaurants and catering facilities, so places that employ more than 250 people, now have to put all of their nutritional information
make it available. So it's only calories on menus at the moment, and some people feel that's a good thing, some people not such a good thing. But if you have a look on most of the websites, or if you do go to a restaurant, you can ask for their nutritional information. They have to have all the for allergies, and so you can ask for that information or have a little look before you go. So all that information will be there for you to hopefully make a better choice, because it's not always that obvious. So don't be afraid to ask. It's, you know, places are actually quite accommodating. So, you know, if you're going to a function, you know, people with allergies and tolerances often have to ring ahead and ask for things to be altered. You might not agree with all the changes we made today, but hopefully you enjoyed your lunch. But, you know, just making a few changes, you can still have, you know, something nice to eat, but it's an awful lot less fat and an awful lot less calories. So say things like changing the lamb to the chicken, and break time is going to be sort of pastries and cookies and things. So hopefully there's something for everybody and people still enjoyed it. Let's say, just don't be afraid to ask. Just thought I'd include alcohol, because I know, you know, lots of people do have a drink. It's just being aware of the guidance. So it's no longer used to be recommended that people have up to, you know, as in men could have 21 units and women 14, but now it's advised not to drink more than, so there's sort of no safe recommendation anymore. Just being aware how much a unit is really. I think a lot of people are unaware of, you know, think, oh, a glass of wine is a unit, rather than, you know, it's actually only sort of a very small glass of wine, or, you know, half a pint of beer, for example. And then also just remembering that there's a lot of calories in alcohol, unfortunately. I think we were sadly enough working out that in a bottle of wine, it's equivalent to about 50 mini eggs, Cadbury's mini eggs. So if you think about it like that, so and your body's gonna you know, burn those calories from the alcohol first. So yeah, it's just being mindful if you're having a pint of beer with your lunch, that would you have a couple of bits of bread extra with your lunch, or a Mars bar as an after. It's kind of calorie wise. So not to say don't have any, but if you are drinking, just be mindful of that. Alcohol tends to stimulate people's appetite as well, so then people tend to eat a little bit more. Sorry, nobody likes dietitians. I always tell all these facts and put people off. So don't forget about exercise. So just put this in here because it's really important alongside diet, is to try and exercise just for general health really, and it obviously has loads of benefits. It's not just about weight management, burning calories, you know, it's sort of mental well-being is really important, cardiovascular health. Just start slow and build up to what you're able to do. It doesn't have to be, you know, putting your lycra and going for a run. It's any kind of exercise, and just trying to build up. So the NHS recommends that it's at least 150 minutes of moderate intensity activity. But wherever you're starting, it's just, you know, starting off and building up, and, you know, sort of practice makes progress really. So doing a little bit every day is really important. Make sure you drink plenty as well, stay really nice and hydrated. And not alcohol, no. Yeah, drinking a beer while you're running. I just put this up here. This is I just took some books back to the library the other day, and I was just walking out, and it's not a particularly big library, and I was just amazed at the array of posters and things that was on the wall. And just in our, you know, it's a small town near us, and there was loads of things on there, and I just thought, you know, so much stuff that you can access, and it's not expensive, or a lot of it's free, and it doesn't have to be, you know, if you're not someone who likes going for like long walks or run or gym, you know, there's dancing and table tennis, and, you know, there was loads of stuff inviting, and I say not just for exercise, but for kind of just like socializing and improving your well-being. There's loads of online classes on the NHS website as well. So if you want to do a bit of exercise in your own home, that's there. There's sort of exercise classes ranging from sort of 10 to 45 minutes. There's seated exercise plans, that sort of thing. And then some people find it quite useful, things like trackers and monitors. Same with diet. You can get lots of free apps that you can track your diet or look up certain foods. So have a little bit of a look around, but the NHS websites are really, really great, and they're all free to access. So And as Lisa said, I think please do get in contact. We're I think it's the day a week we work within the service, but you know, we're always on our emails, and you're welcome to give us a ring. And we love to hear your, you know, anything that you have suggestions for us as well. And then yeah, don't forget the suggestion box that Lisa's lovingly decorated over there. Yeah. So yeah. So yeah, thank you for listening. I don't know if any questions or.
Thank you both. We all know that diet is really important, and I know I struggle. So I know a lot of you in the room do too, and it is difficult. It's a balance, isn't it, like anything? And I think with the exercise as well, a lot of people struggling with fatigue, and what's important to remember is something is better than nothing. So you don't need to be going out running every day. Maybe you can build to that, but even just going out for a 10-minute walk would be beneficial. I've got a couple of questions to kick us off. So first of all, so there's a lot of talk about fat and low fat diets. Obviously with lots of low fat produce, they actually then compensate for the taste difference by increasing the sugar content. And actually fat has been made to, for the last 50 years, has been made to be the evil of obesity. And actually there's a lot of research now suggesting carbohydrates are very important in that story too. And so is there any work being done to look at low carbohydrate diets, and how do we balance that as lipodystrophy patients if we also need to eat low fat?
I think that what we didn't touch on protein really in there, but really important to get plenty of proteins. It really helps to fill people up. So that, you know, any lean proteins, I think some of the swaps that Lisa did on there. I mean, carbohydrates, fine to have carbohydrates, but it's more looking at the, like we were saying, the types of carbohydrates. Wouldn't say overly go for, and you know, there's all these kind of Atkins type, paleo type diets around, but they do tend to be, you know, it's kind of like double cream for breakfast with your coffee, and you know, steaks and cheese and things for lunch. So I think it just depends on you as an individual though, because if you've got very difficult to control diabetes, then you might want to try and have a little bit less of the carbs, but it's a little bit what works for you. But we certainly wouldn't say go no carb and high fat or replace.
No, I mean, I don't think any of us would try and replace it with fat, but maybe it's something we should look into as a group, because obviously we're affected differently from most people in the population, and while keeping the low fat in mind, maybe looking at a reduced carb might be something we could try.
Reduced carbs, definitely.
Any questions?
Something that's a problem, isn't it?
You said that fat was a nutrient, so is there a minimum amount of fat we should have each day, or are we aiming for net zero?
So no, so we're not aiming for 0, 0. So they say, because there are fat soluble vitamins, so things like A, D, E, and K are all sort of fat soluble, and there's essential fatty acids. So we do have to have a minimal amount of fat in the diet. So it is a sensible question. So they normally say about 4 to 5% overall energy from fat, but generally, as long as you've got sort of about 5 or 10 grams of fat in the diet overall, then that should be enough to sort of prevent sort of deficiencies from too little fat.
Anybody else?
I've recently got into baking, and I found a low carb flour, so I make my own bread. It's really easy, and sugar-free jam, which is also very easy. And I'm no good at all that, but so I made bread and butter and jam, and it didn't affect my blood. So I was over the moon because I love bread.
Fantastic. Well, if you would like to share any of those, if you want to share the recipe with Becky, she can put it on the Facebook group, or you can email us and we can add it to the suggestions things.
Great, good tip to share. Anybody else?
Have you got any advice for gluten-free? Because I tend to find if I look at gluten-free, it's laced with sugar to make it taste better. So then I'm still struggling with the blood sugar side of things as well. So I'm left eating.
Yeah, I think it is true when you do look at gluten-free stuff, they do put more sugar and fat into it. I think they are getting a bit better with some of them now, but I think most people tend to then just try and go for the naturally gluten-free things instead. Like, you know, potato and rice, for example, with not so much of the breads and the cereals. I mean, you can get the gluten-free things like porridge, for example. No, don't. But I'm happy to have a chat with you though if it's useful separately. Celiac UK have got a really good app as well. So have a little look at that app. You can scan foods, check. Yeah. Yeah, no, it's very, yeah.
So again,
took it off
let's share some
prescription.
tips on what people have found works and is nice to eat.
Yeah.
Any other questions? No, so one last,
Right. Are collagen supplements fatty? And is that useful for joints, etc., for your nails and skin? Is collagen, you know, these collagen products, collagen gel, and that's consumable?
I don't know. I'd have to have a look at them. Do you know? No.
Is it any good for? Is it helpful, or does it add to your fats? Because I don't know what collagen's
I
made
don't know. I'd
of.
have to look at the food label. I'd have to look at the label, the back, all supplement. I mean, it should say on the back if there's any fat in it.
It just says collagen, whatever.
Oh, does it?
Yeah, it just says collagen. Doesn't say fat content or anything.
But whether sometimes they put them in like capsules, don't they, and with oils and things. But
yes, sometimes it's
just
gel,
sometimes the ones
sometimes
that
it's
are kind
tablet form.
Yeah.
But, sometimes there's capsules, but
I suppose if you think about how big the tablet is, it might not be.
I think it just depends how many you'll have, like, because some of these hair, skin and nail ones, they add in like omega-3 and other stuff, and then if you have to take, I don't know how many you have to take, you maybe take a picture of the box and you could send us it on email or something.
One last question for me, just quickly. So obviously you're dietitians rather than your expertise being in exercise, but since you talked about exercise, I'm going to ask you. A lot of us deal with excess visceral fat because there's nowhere else to store it. Is there, what's the best type of exercise to do that will target that kind of fat, but not put on extra muscle mass? Because that's the last thing some of us want to do. It's okay not to know the answer, but
I don't know. I mean, I guess it'd be any kind of cardiovascular kind of exercise, I would have thought, because if you're walking and running, I suppose, yeah, I would have thought. I don't know though. I would have thought that
maybe we can find out.
Yeah, not weights and stuff. But yeah.
Yeah, no, like Catherine said, I think it would be basing it on cardiovascular exercise. I think for weights, they suggest sort of more repetitions of a low weight would build up sort of strength rather than muscle mass.
Great. All right. Thank you.
Thank you.
So thank you very much to Catherine and Lisa. It's very informative. And as they say, please share any hints and tips, recipes or products that you found that work for you. The kind of larger the database, the more people, you know, we'll be able to help with that because everyone has different preferences. So that's great. Next, we have fantastic talk from Tom. Some of you may remember Tom from our series of videos we did, I think it was back in 2020 for World Lipodystrophy Day, who did a talk on exercise and living with lipodystrophy. And today he's going to give us some insights from his journey.
A mic. Oh, okay. I've got a mic. Go back forward, please. Oh, okay. Oh, can everybody hear? I'm all mic'd up. Hello. Wonderful to be here. Wonderful to be able to speak to you all. It's actually the first time I've other members of my tribe, if you like, with lipodystrophy. I've spoken at a few different medical conferences, but this is the first one I've had the pleasure to really connect with the tribe. So, hello. I have to, first of all, give a huge thanks to Siobhan and Becky and everyone, all the other trustees of Lipodystrophy UK for doing such a wonderful conference for us. I hope that you've all enjoyed yourself and the wonderful speakers we've had so far. So thank you for inviting me. That's really nice and much appreciated. We've had so far a number of fantastic speakers. They are qualified doctors, qualified dietitians, qualified psychologists. I'm not. I'm not qualified in any of those areas, really. I'm here to speak to you today to provide, hopefully, a slightly entertaining interlude and a bit of a patient perspective, because I have lipodystrophy, and my story is quite interesting. I've attained a very, very small level of success, a very small level of notoriety on social media, largely through emotional blackmail and my inherent sexual charisma. You've probably all picked up on it so far, I can tell. Patient day. The title of this particular presentation is Rare Warrior, a journey to sporting success and becoming your own expert, helpfully suggested by Becky, because like most people, I hate talking about myself. And really it's just a means to an end, and it's a vehicle to try and tell the story that I'm trying to tell you today. Unfortunately, that will mean that I have to talk about myself a little bit in order to basically get across some of the lessons and some of the insights that I'm hoping to impart today. So, for those who don't know, who am I? My name is Tom Smaniford, and in 2013 I was diagnosed with something called MDP syndrome. MDP syndrome is has the curious, infamous status, if you like, of being one of the rarest diagnosed conditions in the world. There are 16 of us identified worldwide. So in a global population of 7 billion, everyone says, well, I'm 1 in a million. Well, I'm 1 in 637 million. Which obviously, if I was still dating, I'm sure that would be a really useful open line of, what a catch. So MDP stands for executive hyperplasia, deafness and prodromal features, and there are a number of attractive symptoms of this condition. The small lower jaw, which obviously often results in teeth overcrowding, because we have a small mouth but normal sized teeth, so it's like there's not enough space for everything. I actually solved that overcrowding issue myself by diving first through the windscreen of a car when I was out cycling, and basically ruined all my teeth, and most of my front teeth are fake because of that, but conveniently sized, so problem solved. It's not something I'd advise people to do. Don't go diving through the windscreen. It's never a good thing. Deafness. I started off during puberty. I noticed I had some hearing loss down to moderate to severe hearing loss on a sensory neural basis. Unfortunately, that has now progressed, and I'm basically profoundly deaf in the left ear and functionally deaf in the right ear. That just doesn't pick up any speech. It's more of it provides me with the kind of 3D spatial awareness, background, atmosphere, sound. Tightening in the skin, because obviously as part of having full lipodystrophy, which is one of the symptoms, I have no subcutaneous fat. So no fat under the skin, which is common to lots of you and lots of different types of lipodystrophy. And I have obviously a predisposition to storing it on my organs, which is not nice. And males who have MDP syndrome also have low testosterone, which is fortunately largely resolved by injections every 3 months or so. And then one final thing related to the lack of subcutaneous fat is all the tendons in my feet tighten up and make walking very painful, even with custom insoles and custom shoes and so on. Those are the symptoms of MDP syndrome, and seriously, every single person who has MDP has all of those. And it was one of the ways that they were able to actually identify us, 16 of us worldwide, which is incredible odds, was because the single genetic mutation that basically caused this condition caused each of these exact conditions in everybody. So it wasn't a case of, oh, some people have a few, or some people have this or don't have that. Every single person who has MDP syndrome and has that genetic mutation has all of those conditions. We also look scarily similar. It's like we are a clone army. Additionally, I have beyond that, these are obviously my own additional conditions, just to spice things up a little bit more. My profound deafness, I've already mentioned that. Keratoconus, which is a genetic condition whereby the corneas in my eyes are no longer circular, they're changing shape. So that means that I basically can't focus as well. Left end check, they would basically keep changing shape until I wouldn't be able to focus at all. So they do this really horrible thing called corneal cross-linking, where they shave off the front of your eye and they dribble stuff into it. That basically, it's basically Botox for my pupils, and it firms them up. And it doesn't improve my eyesight, but it means that there's no further deterioration. So it's better than nothing. And then type 2 diabetes. Seriously, that is related to specifically to my form of lipodystrophy, in that because I have such high levels of fatty acids in the blood, it's tricked my body into thinking I'm morbidly obese. And obviously I'm not, I weigh 63 kilos. The medical journal that basically identified lipodystrophy is here. It was done by Mike Median, who was a very good researcher at University of Exeter, and actually one of his colleagues, Rob Semple, who was one of the accredited authors on this study as well, is here today. So I was the actual journal article which identified MDP syndrome as a condition was published in 2013, which is when I was 23. So what did I do until then? I know that for a lot of you, not being able to gain a diagnosis or know you have lipodystrophy due to the rarity of it, and the fact that so few doctors really are aware of it as a condition or a group of conditions. And so ignore it and just to get on with things, because it didn't seem like there would ever be a diagnosis for all of my curious different symptoms. And because they were so disparate, it seemed like the best thing to do. So what did I do until that point? I studied UK, French, EU, US and international law at the University of Exeter. I lived in UK, Germany, Cyprus, Kuwait and France, largely as a result of the fact that my dad was in the armed forces, so army could move around anyway as a matter of course. I play classical guitar, grade 8 pieces, which is obviously quite unusual for somebody who is profoundly deaf and also has tiny hands. I speak French fluently. I have a master's in EU law, which I gained from Rennes in Brittany in France, where I studied EU law as a French person in French. So I wasn't there as an English student, I was there like a French student studying it in French. That's particularly interesting because not many people who have severe hearing loss speak another language, never mind speaking it fluently enough to study law in that language. So it's quite a tricky one, but it does mean that I'm now essentially qualified in common law and civil law jurisdiction, because obviously the EU is civil law, most of Europe is civil law, we have common law jurisprudence in the UK. So most of the world's legal systems, with the exception of America and Australia, which are federal, have either a common or civil law jurisdiction. So that familiarity is useful. And I raced bikes, as you can see. I raced road bikes for 2 years for Great Britain in UK, France and Spain as a member of the Great Britain paracycling team. And in 2011, I was actually the senior national paracycling champion, which is why I get that lovely aqua fresh cycling jersey, because when you win a national championship in cycling, you wear the bands, as they're known. The national champion strikes for a year up until the next, obviously, national champion, when the next winner wears it for the year, and so on. So one thing I'm often asked, and one thing that I often ask myself in this situation is, would I have done all of that if I was essentially wasting my time waiting for a diagnosis and a cure? That's in no way to disinherit or to suggest that wanting a cure or wanting a diagnosis is in any way negative at all. That's not what I'm suggesting. I think that obviously we all have, as humans, a desire to understand our place in the world and understand how we connect with others, how we identify ourselves, how we structure our self-esteem. And those questions of overdiagnosis and what's wrong with me is a common fear. And really, there's nothing wrong with you, you know. It's just that, you know, there are some things that at the minute are unexplained. And I think that, as I've said, my approach has always been that treatment is more important to me than diagnosis. And then we have a lovely picture there. And the reason why that's there is because I have something that I've pondered on over the years that I like to call umbrella theory. And it's something that I want to share with you today because it's been really useful for me as somebody with a rare disorder or rare condition, in that I like to think of having a rare disease or a rare condition as being out in the rain. And certainly if you're undiagnosed or if you're seeking a cure or you're seeking a diagnosis, you basically focus on that. But actually, there are many things that you could do to improve your quality of life without knowing that diagnosis. And it's a bit like putting up an umbrella in the rain. So when it's raining, you don't need to know about the nitrogen cycle or the atmospheric conditions in the clouds above, or even how rain works. If it's raining, you put an umbrella up. And your life is immediately improved because you get to stay dry. You don't need to understand how the weather works or rain works. You don't need to make a comparison with the weather in other countries and say, oh, well, he doesn't have this condition, he will understand. And similarly, you don't say, well, it's not raining in Oxford. Well, that's irrelevant because the only thing you're interested in is your situation. Is it raining here on me? What can I do to change that situation? Well, I can put an umbrella up. And so sometimes the best thing you can do for yourself, I'm not religious, but there's that religious phrase, God helps those who help themselves. And it's especially true for having a rare disorder, that nobody can have all the answers. We do not know all the answers. We probably never will have all the answers. But that doesn't mean that you can't have a significant and positive impact on your situation by making some careful choices. Or just by thinking, well, I don't like these socks. They're really, they're rubbing me and they're painful. So change your socks. My feet, I find it really difficult walking in these shoes. So use different shoes. And it seems we almost forget, because we're always looking for a bigger answer, a silver bullet, if you like, that resolves everything. And actually we forget the small choices that we could do on a daily basis that actually would be really, really good for us. Like we had that wonderful presentation just now from Catherine on the dietary guidelines, and they said, you know, one of the most important things they said was to actively adjust the advice to suit your situation. It should be tailored. It's like, if you know you have a massive craving for chocolate that's not going to go away, don't pretend you don't crave chocolate. Just find a chocolate that's lower in fat that will help you scratch that itch and satisfy that chocolate urge in the healthiest way possible within the accepted medical guidelines. So these are what I basically did to resolve my issues, which is obviously I'm deaf. It's not going to change. Oh, wait, here it goes. Well, there we are. It's largely resolved a lot of those issues. I told you about the corneal cross-linking. It's not. I didn't really choose that. It was more, despite the fact it was quite uncomfortable. And for my type 2 diabetes, I obviously modified that with exercise by riding a bike, a ridiculous, stupid amount, and also eating lots, which is one of the benefits of riding a bike, lots. Connective tissue tightening, again, being active, being healthy, doing lots of exercise meant I had good circulation, which in turn meant all of the tendons and ligaments and connective tissues were kind of well circulated with blood, they were warm, stretching was a lot easier. I could stretch on a regular basis, which in turn helped me continue with my flexibility, which meant that exercise was more comfortable, which meant, and there's basically there's a cycle there of positive benefit. Painful feet, obviously custom shoes to help with that, and then just basically using your feet, because obviously resistance training, you lift a heavy weight, it's heavy, it hurts, you go away, you recover, you come back, you find you can lift a little bit more. And the same is with foot pain. Your feet are hurting, you walk maybe 100 meters one day, you recover. Maybe next time you try for 105 meters or 110 meters. And so you kind of, you treat your reception or your perception of pain just as you would with training for fitness or training to build muscle. And then obviously flow testosterone injections every quarter. So my overwhelming philosophy is that I'm not aiming to find a cure. My aim is to improve my quality of life, because the cure does not change anything for me. And actually, one of the things that the media never chose to focus on when the diagnosis came in 2013 is that my life did not change one iota after diagnosis. Having a diagnosis in 2013 made absolutely no difference to me whatsoever. All of the things before diagnosis I was already doing, and after diagnosis I continued to do them. The diagnosis itself has not changed anything. In future, it may change things, because obviously there's this team of wonderful researchers who are working very hard to find out and answer these various different questions that may in future lead to potential other treatments, potential other therapies that may benefit me. But on an immediate basis, the diagnosis meant absolutely no difference to me, apart from the fact that I could now say, I've got MVP syndrome, which is of questionable value, because everyone then goes, what's MVP syndrome? And so, oh, yeah, you don't know it? Well, there's only 16 of us worldwide. So, and then I invariably have to send them to Google, which basically does the work for me. So, bell curves and outlines. One of the things that I want to circle back on, if you like, and it's something that actually they mentioned in the wonderful previous presentation on diet, with actively tailoring the diet to your lifestyle and your metabolism, is that most medical treatments are obviously, and most things in life are tailored to the bell curve, which is that the average person features in the middle of the bell curve, and then we have outliers. And similarly, for drug treatments, we say that this drug is extremely efficacious, it's effective for the majority of people in the middle of the bell curve, and less effective, or indeed more effective, for people on the outside. So the important thing to remember is that within the bell curve and within the provided qualified medical advice, which I really must insist you follow, there is some variation. So for instance, I take metformin for type 2 diabetes, and my dosage is 4 tablets a day. Now, when I take those 4, it doesn't really matter provided I have it with food. So originally I was on 2 with lunch and 2 with dinner. And I found that on a personal basis, that didn't work for me because I wasn't having a huge amount of carbs at lunch. And what that meant was because I was very, very sensitive to the insulin sensitivity medicine at lunch, I was having big blood sugar crashes in the afternoon. So what I did was I changed it and have 1 tablet for lunch and 3 tablets for dinner, or indeed just 4 tablets for dinner, because in the evening, my insulin sensitivity was really, really bad. So that's basically when I needed the dosage the most. So all of that is within the medical advice, but there's just a small tweak that I did that, for me, had a massive, massive effect. And similarly, you will be on medications and you will have a routine and you will have certain treatments and therapies that you do, where a small tweak, because you become your own expert and you know how you respond to these things, could have a really big mental and physical positive effect. So that basically is just clarifying all of that again. I kind of got ahead of myself there actually, we're just repeating it. So let's get through that bit. We just kind of go very quickly. Yeah, so insoles, great, they make them for me, but I'm always telling my orthotist, don't do that, it's rubbish, it doesn't work. I need extra padding here, here, and here, because they're the bits that hurt. Compression bandaging, at the minute I'm having compression bandaging on this leg because I have an arterial ulcer on this ankle. And of course, the nurses at the tissue viability wrapped it all up in compression bandaging, not realising I have no subcutaneous body fat. So when you're doing compression bandaging around skin and bone, it rubs. And so I was basically, the compression bandaging they put on to heal my wound caused me some new wounds in other places. And so I continue now with bandaging up and I'm healing the new wounds that they gave me. The original wound is healed. And again, this is the thing that tailoring the medical advice is really important, and the best person to tailor it, or rather the best person to know where you deviate from the standard is you. You are the expert of yourself. This is something that I always like to do when I'm speaking to people with rare diseases. And we're going to go through a number of characteristics of what it is to have a rare disease or a rare condition. And basically, if you agree with it, raise your hand. This is the interactive section of the presentation now. Really exciting. Come on, yeah, as a team we'll do it. So, do you follow a strict diet catering to your specific metabolism as your condition? Yeah, I think most of us, we will follow a diet, or at least we try to follow a healthy diet. Questionable, heavy on the jack approach sometimes, isn't it? I sympathise. Changes to your routine result in negative physical effects. So many of us have a really strict routine at home. If you don't follow the routine, you find that you've got some issues. It's a common thing. You have to be very careful and regulated with regard to activities. So you can't spontaneously decide to go on a 4-mile walk in a way that a normal person might do. Okay, not very many normal people would do, but that's one thing that, you know, we have a routine. You have to be careful with regards to changes to that. Are you dependent on custom and specialised equipment just in order to function normally? Well, obviously I am, because I have insoles and shoes, and maybe some of you use crutches or wheelchairs to help get around, or maybe you have adaptations in your cars, or special shocks, or a special bed mattress, for example. Do you have a lost or reduced ability to do many everyday normal functions? To the shops. I mean, I never walk to the shops because I don't really walk, but there are lots of things that I don't do that a normal person would just consider every day. And that's a common occurrence for people with rare diseases. And this is a big one because almost everybody does this on some level. And do you find yourself worrying about your current physical state and have fears about the future? I think we could all, on some level, confess to that one. So these are all the characteristics of somebody who has a rare disease and disorder. Has anybody noticed what they're also characteristics of? Because all of these characteristics are also shared by one other, very, very specific group. No? Anybody notice? No? These are the same characteristics of an elite athlete. Elite athletes have to follow a really, really strict diet. Elite athletes hate changes to their training routine. Elite athletes have to be really careful with regards to training within specific power zones or heart rate zones at certain times of the day. Elite athletes are dependent upon custom insoles if they're cycling. They're dependent upon specific grips. They're dependent on adaptations to their rowing boat, etc. They've lost their ability to handle many everyday and normal functions. I hang around a lot with pro cyclists and people on Great Britain cycling. If you've ever heard the whining that goes on in a cycling team when they have to walk anywhere, it's oh my God, it's like, it says, look, trying to go to the shop and get a packet of crisps, and they're like, it's like you ask them to sell their firstborn child into slavery. And literally, it's because we spend so much time pumping away on the pedals. Walking feels alien, like it feels like really unhealthy. And similarly, people who do lots of squats and deadlifts in the gym, have you ever tried following them up the stairs? They don't like stairs, you know, they really struggle with them. And then finally, basically performance anxiety. Where athletes, they worry about the future. Am I in form? Am I fit? Am I going to be ready for this competition? What about, what if I get an injury? What if my main competitor is going to turn up and be really, really strong because he's had a fantastic winter of training? Do they have fears as well? Why am I mentioning all of this? Because there will be days when you feel really down, and there will be days when you feel like you are failing at life and nothing is going on, and walking or even putting your clothes on or getting out of bed is an effort, and like you are somehow, everything is a struggle. What I want to remind you is that you are living the lifestyle of an elite athlete. Even they have days where they just want to stay in bed. The only difference is that at the end of it, they get a massive paycheck, which probably we won't be getting. So it's really important to remember that you basically adopted an elite athlete lifestyle with none of the benefits of having an elite athlete. So don't beat yourself up. You are doing something that very, very few people in this world are able to commit to. And you're doing it for far lesser benefit or payback than the people who actually do it. So I think it's really important that you remember that and change your perception of the fact that you're thinking, oh, I'm just impotent, I'm just useless, I am basically an invalid, I'm a cripple, I can't do anything properly. No, you're an elite athlete. You just happen to be in a race that nobody's paying you for. And really that mindset switch can have a massive, we spoke earlier with Fabio's wonderful presentation about how the perception of how people perceive us and also your perception of your visual appearance is the most important thing. And it really is true. Changing your mindset is the most important thing. And you've got a quote from Maya Angelou, who's one of my favourite writers. If you don't like something, change it. And that basically, we're talking about the treatment options I mentioned before. Get better insoles, have softer socks, change your mattress, get a pillow that you like. Do these things that have an immediate positive effect on your quality of life and make you happier. And then if you can't change it, like there are certain, I'm not saying that you're going to wake up one day and say, you know what, I've decided I'm going to buy a pair of Michael Jordan Air Force One trainers, and then next year I'll probably play in the NBA. Realistically, it's not going to happen. However, you know, within the boundaries of realism and expectation, there's lots you can do. And then when you can't do something that will improve it, you have found the softest socks known to man, and there's no softer sock possible. Then the next thing you need to do is think about whether you are over prioritizing sock comfort, and maybe you should be focusing on something else. So that basically is the summarizing quote for this really, really overlong talk. I'm sorry, I haven't been watching it. We were going to have some questions at the end of this, but we're not bothering now. We're just going to. So, yeah, questions if we have time. Next section is going to be really difficult because I am deaf as a post and I can't hear any of you. So what's going to happen is, you have a question, you wave, the lovely Becky, my wonderful assistant here, is going to rush over to you. You're going to ask her, she's going to rush back and then give me my interpreter and tell me the question again.
On it. That's fantastic. Thank you so much, Tom. I don't know about you guys, but that's been my favourite talk so far today. And it's really nice to focus on what we can do and not what we can't do. And you're very right. It's all, a lot of it is about attitude. And, you know, I've always said this, we are our own best advocates as patients. We know our bodies better than anybody. We don't necessarily understand the science or, you know, the medications or the research, but you don't have to in order to fight for what's right and what will help you. So, you know, educate yourselves, look after yourselves and advocate. Questions? Yeah. Maybe it's a question.
Really, we should have had little like scraps of paper and we can like just put and just like.
So the question is, when is your autobiography out? And if it's not already out, when is it coming?
The problem is we don't have time to write it. I don't trust anyone else to write it for me.
Change your attitude. Change your attitude.
Yes. If we could maybe do a film instead of the autobiography, we'll do an autobiographical film. And obviously Brad Pitt would play me. It's a natural choice, okay? It's just a natural choice.
Yeah, I was just going to say, I saw him in the programme, about 10 years ago, is it Tom?
I'm sure you was on it might be the BBC, about a guy, and it must have been you, who was cycling all round Britain, who said that he had to lose weight because he was technically overweight, but obviously not. You was on telly, yeah? You was on a TV program.
I didn't get any of that.
TV
program?
sorry.
Were you on a TV program
on a-
talking about your cycling and needing to lose weight? No.
He was, 'cause I spoke to him earlier about it, and he said it was in.
But unfortunately, it's been 10 years since the diagnosis, and because the diagnosis of MDT, one of the reasons that it was picked up by the global media is because fat and topics about fat and headlines about fat are considered really sexy, and they really sell well. Like whenever there's a new diet pill or there's a new fat thing, as a society, as a civilization, we are obsessed with fat. So that's one of the reasons why my story or the MDT diagnosis went everywhere. And I've completely lost my train of thought. What was it? Oh yeah, because of that, lots of, in the 10 years since, I've done 7 or 8 documentaries now with BBC, Channel 4, RTE, Discovery Channel, Sky, all of them focusing on cycling. And the tagline, the man who can't get fat, which is a lie, okay? It's just a complete lie. And they seem to think that I can spend my days sitting at home with a KFC bargain bucket, you know, just eating away and never getting fat. No, it's just going to kill me inside. And I think this is one of the issues we have with conveying medical information to the public, is the public is stupid.
Any other questions?
It's not so much as a question as I'll probably speak for most people here that it's absolutely refreshing to hear something positive, fun, instead of focusing on all the negative things. It's been really wonderful to hear just a beautiful story in a way of just positivity and how we can all focus on just the good instead of all the negative. I just think is amazing.
I didn't get any of that, but I don't know what you're talking about.
As I said, it's fantastic to hear a positive story, really inspirational, and you know, got real enjoyment out of a beautiful story of, you know, the good side of things. So thank you very much.
Thank you. Thank you for being there.
Thank you very much. We're going to move on to the next speaker. Our next speaker today is Erica. She's a PhD student with the University of Hertfordshire, and she's been working with us on the chronic fatigue study that we initiated and are working with Adam Brooks and a couple of other people. So she's going to give you a bit of an update on that project. And where is Erica? There you are. Fabulous. Thank you.
What's this? Okay. Hi everyone. My name's Erica Bridgewater. I'm a master's student at the University of Hertfordshire studying research in clinical psychology. As Becky mentioned, we're doing a patient-led exploration of chronic fatigue in lipodystrophy. So I thought I'd just sort of update you all on it. A little bit of background to it. It was developed, led by, anyway, Lipodystrophy UK. It's a qualitative study, which basically means that we conduct interviews with people, with adults diagnosed with lipodystrophy, to explore experiences of fatigue while you're living with the condition. It's connected to the Life study by the Cambridge Patient-led Research Hub. Who's involved? My supervisor, who's a clinical psychologist and lecturer, Saskia Cavell, is the principal researcher, while me and 2 of my colleagues are doing the interviews for it. Participation is optional and on a voluntary basis. We're still looking for people to volunteer to be involved in it. So if you are interested, there'll be more information on that at the end. All the inclusion criteria is you need to be self-reported with, obviously, lipodystrophy, be over the age of 18, and to be able to provide informed consent so that we can obviously actually do it. The aims of the study is just to explore the impact of the chronic fatigue on the quality of life of individuals with lipodystrophy. These interviews will be semi-structured, so there'll be like a set list of questions, like open-ended, about your experiences of living with the condition and your chronic fatigue around that, how that might be impacting your life now and in the past. Yeah, so if you do want to contact us to be involved, you'll be provided with an information sheet that will give you more details about the study. Be invited to give consent by signing the informed consent form. Fill in a demographic questionnaire that just tells us a little bit more about you, like your age and little bits like that. And then an interview time will be arranged, usually by email, by me and 2 of my colleagues. Once the forms are all completed, the interviews themselves will be taking place over a video calling software. I've used Zoom so far, but if that doesn't work, we can use Teams or phone call or anything else really that works better. And it should last around 45 to 60 minutes, depending on the interview itself. These will be recorded using the Zoom recording function, but obviously for confidentiality, we'll be deleting these recordings immediately after I've transcribed them, which is just writing it up word for word so that we don't have to have the video anymore. And obviously your names will be completely removed. Anyone else's names that you mention will be changed into something completely irrelevant, as to keep that all confidential. Once the interview has ended, obviously you'll all be thanked for your time, given a debrief sheet which has all of our contact details, which will be shown at the end, and a debrief sheet that, well, the debrief sheet has all of the other information on it, like Lipodystrophy UK probably. Once all this is transcribed, we'll be analysing this using thematic analysis, which essentially, once we have the coded transcripts, well, we'll code these, which is essentially making it a bit shorter and easier to look at, and then put all of these next to each other and find shared patterns of meaning across all the transcripts to create themes, essentially. We can't say too much about it as of yet because we haven't finished doing the interview, started analysing very much, but there are a few things that I have noticed myself so far from the interviews, such as a lot of the time, warmth is used as a coping mechanism for coping with fatigue, as it seems that fatigue happens for a lot of people to be worse in the colder weather. So a lot of my participants have mentioned being always wrapped up a lot more than the average person, using heated blankets and stuff. But also on the other hand, in the summer, if it's like really hot, there's the flip side of that where you're then tired because it's too hot. So it's, yeah. We've also found there's quite a big impact of support systems. So I've had, for example, I had one participant that her family completely understood from the get-go. Before she was diagnosed quite late in life. They understood completely and utterly, and that was just the way she was, that there was no problem with it. And that made her general well-being a lot better. Whereas I had a different participant whose family still, after being diagnosed, they understand it more, but don't really accept it almost in a way. Very similarly with work life, I had one participant that before diagnosis, she got diagnosed around 45, 50, I think it was. Her bosses just didn't care at all almost. If there was like a group meeting, she said that she'd always have to go first, because if she left it any longer, she'd just fall asleep, and that was just the way it was. And she'd wake up and have all of her colleagues like giggling at her because they just knew that she'd fall asleep. But that sort of understanding seemed to have made her life so much easier. Whereas I've seen quite a lot of people that have had a lot of problems with work, because obviously like falling asleep in the workplace isn't taken very lightly by a lot of people. I've also seen snacking as a regulator for fatigue, but only for one person as of yet, but I thought it was quite interesting. Couldn't get on with the idea of having the 3 meals a day as she was sort of advised. So pretty much to keep herself going throughout the day, snacked on like little like bananas, saurine bars, little bits and pieces, like just grazing throughout the day, seems to keep her awake and functioning for a lot longer than it would normally. But I thought that was quite interesting. Finally, I've had quite a lot of people, they've had the same sort of attitude around their condition. They've had a lot of struggle adapting to it, but I think that comes largely from being diagnosed so late in life. It's probably harder to sort of adapt yourself to it when it's taken so long to get there in the first place. But at the same time, they've all had a sort of, well, it is what it is. Don't let it get to you. This is just my life and that's the way it is. And I'm not going to let it bother me. In the same sort of, almost the same paragraph, they'd say like, oh, you know, I still like forget about it, burn myself out. Like I'll do way too much. And then like, I'm absolutely knackered within 10 minutes. But like, oh, well, it's just that they've all had, you know, a really strong mentality, but that's all we've sort of found so far because we've not done too many interviews as of yet. But yeah, that is, I've got on here all of our contact details. If you are interested in taking part, please do email any of us and we'll get back to you. But yeah, that's me.
Thank you, Erica. It's really good to have researchers come and join us and tell us what they're doing and involve us in those studies. So thank you very much. Have we got any questions for Erica? No. So we've got information on the Facebook page about this study, but we make sure we signpost it. And if you're interested to sign up, please do, because it is a rare condition, so it's difficult to get the number of participants you need to make progress. And if you want progress, you've got to be involved. So yeah, great. Thank you very much.
Thank you.
So now we have a refreshment break. I'm not sure what's the time. Hello. Hope you've still got a little bit more energy because we've got one more talk this afternoon. We've got a talk from Stephanie Yin. She is psychotherapist and specialist counsellor at Rare Minds. And she's going to talk to us today about looking after your emotional well-being. I know I struggle with my mental health, and I'm sure a lot of you do too. So hopefully we'll get some good tips.
Thank you. Feel a bit of pressure now to give some good tips, but yes, thank you for having me. So yes, my name is Stephanie. I'm a psychotherapist and a specialist counsellor. I'm a core clinical team member of Rare Minds. Just before I start, I'm kind of aware that today's, you know, you've had a lot of really great talks, been sitting on these chairs, and I thought I would just start off with a really quick kind of grounding exercise, if that's okay. So it will be really quick, I promise. Hopefully it will make you feel a bit more enthusiastic about this talk. But I just want to invite you, if you feel comfortable to do so, to just close your eyes and just get comfortable in your chair. Just feel how it feels on the chair, but mostly focus on your breathing. Just take a moment to just pay attention to your breath as it comes in, as you breathe back out. Just focus on your breath and try to recognize, where is the breath going? Does it feel in your chest? Does it come all the way down to your abdomen? And just stay with that for a moment. And then I'm just going to invite you to bring your awareness back to the room, to the aircon that we can hear, to the people around you, and to just gently open your eyes back up again. And that's it. Hopefully not too painful. So I just want to introduce what Rare Minds as an organization does. So we are a community interest company. We were established in 2020 to provide specialist mental health services for the rare disease community. We also deliver workshops and provide training and undertake research to raise awareness for rare conditions. We do believe that we're the only third sector organization in the UK and possibly worldwide focusing in this area, although I'm always happy to hear if there are other organizations doing the same work. Our focus does come from our belief that those living with rare conditions are a unique population with unique needs that often are not addressed or understood by other services. And many of us in the clinical team also have our own lived experience of rare conditions. So Rare Minds delivers specialist counselling by partnering with patient organisations and assigning members of the clinical team, such as myself, to work with the organisations throughout this partnership. And that allows us as counsellors to gain a greater understanding of the unique experience and challenges of a particular diagnosis, and hopefully create strong, long-lasting relationships as well with that community. So I'm here to talk about the impact of living with a rare condition, how to recognise and manage some of the perhaps more difficult stuff, and to signpost on how you might access support. And I just want to acknowledge from everything that we've heard today that there are, of course, different presentations of lipodystrophy, and that might lead to very different lived experiences, just as individual differences can also impact your experience of living with lipodystrophy. I also want to acknowledge that mental health is actually such a broad topic and that there's only so much that we can cover today. So today's talk will obviously be fairly limited. However, I do hope that you'll hear some things that will resonate with you and that you'll be able to take away perhaps some tips on how to manage some of the difficult stuff, as I mentioned. I will also be hopefully signposting to some helpful support. So, we know from experience that living with a rare condition is very emotionally demanding. But just to put it into context, I just want to share with you some of the statistics from a study done by Rare Disease UK in 2018. So they did a survey with 1,300 patients and carers with all different types of rare conditions. And this is what they found. 95% of people reported feeling worried or anxious. 93% reported feeling stressed. 90% felt low. 88% felt emotionally exhausted, and 70% felt at breaking point. And the reason I want to share these statistics is just to say that if you do feel sometimes that you're struggling, just know that you're not the only one. So what is it actually about a rare disease diagnosis that impacts our emotional well-being? And often it starts with the diagnostic odyssey, which is a term you might be familiar with, which sort of encompasses the kind of arduous journey that it takes to get a diagnosis sometimes. It might have involved multiple visits to healthcare professionals, experiences of not being believed, feeling that you're not being heard, having to fight to have your experience acknowledged and heard. And unfortunately, that fighting to be heard doesn't necessarily stop just because you have a diagnosis. Sometimes you might be fighting just to have access to support, to grants, to lots of different things. Often the fighting has to do with the lack of awareness into a condition, such as ultra-rare conditions like lipodystrophy. The lack of awareness also might mean that you have to keep explaining your condition over and over, which can be quite frustrating or distressing, particularly in non-medical settings. You might also be having to deal with how others respond to your diagnosis, which might at times be really supportive or sometimes very dismissive and hurtful. A diagnosis of lipodystrophy might also bring about worries about the future. How will the condition impact you over time? What might treatment options look like? And so on. Diagnosis might impact your family life as well, the dynamics, how relationships form. And of course, it's important to acknowledge, especially now with things like the rising cost of living, that living with a rare condition can be a very big financial and logistical burden, having to get to regular appointments, having to pay for specialist equipment if it's not funded, and so on. And all of these things have a huge impact on our emotional well-being. And I just wanted to also acknowledge some perhaps unique things, unique characteristics of lipodystrophy that can impact day-to-day life and emotional experience. These might be changes in appearance, which might impact your body image or self-esteem. the metabolic disturbances, which require very strict dietary and exercise requirements, which we heard about today, and that might impact lifestyle. It might mean having to plan meals out in advance, things like that. Pain and fatigue, which is a physical experience, but again, I'm sure you can acknowledge often has a huge impact on mood as well. And the impact on fertility may also impact esteem and relationships. So I just want to share a few words here that are kind of common feelings that people talk about in terms of living with their diagnosis. And by no means is this list exhaustive. It's just 12 of the common feelings. And I'm just going to go through them. And I just want you to just notice if this is a word that connects with you, if it's something that you've experienced, and perhaps are some of these feelings harder to accept than others. Anxiety, relief, fear, anger, grief and loss, shame, low mood or depression, disbelief, envy, resentment, despair, feeling numb or nothing. And I just want to acknowledge that all of these feelings are natural feelings to have. There is no right or wrong way to feel. But obviously, sometimes these feelings can be really hard to manage or feel very difficult to accept. So I guess if there's one thing that you take from this talk, I hope that it's this, that actually we spend a lot of our energy trying to resist how we feel, trying to fight a feeling that we may put a negative judgment on, sort of something like anxiety, that we're kind of told you shouldn't feel overly anxious. Well, that's really hard. So one of the ways is to rather than try to fight that feeling, is to simply notice it and just try and name it, to sit with it and acknowledge what I'm feeling right now is anxiety. And this is a really important step, is to not judge that feeling. And more importantly, to not judge yourself for having it, to not try and say, you're so silly for feeling this way, you shouldn't be anxious, it's fine. To just acknowledge that that is how you feel and that's okay. And then maybe think about what would help in this moment. Do you want to talk to a friend? Do you want to reach out to your partner, a family member? Or perhaps you want to take a change of scene, maybe go for a walk or engage in some exercise, or perhaps do something a bit more creative, do some writing, music, listening to music, or find something distracting. But the main thing is to learn to sit with that feeling and to let it pass. And remember that feelings ebb and flow. This feeling is not going to last forever. So there was interestingly a container earlier in the dietitian speech, and just saying about, that you need to be aware that your container can fill up and overflow. And actually, this is a metaphor that I like to use to symbolize our internal container for stresses. And that represents our capacity to deal with things like everyday stresses, which we all experience, having to rush to work, having to pay the bills, and then much bigger stresses, life event stresses, things like a global pandemic, a rising cost of living, and so on. So all these things come in and they fill your bucket, and obviously they empty as you engage in self-care or as you manage those challenges. And certain things take more or less space. So at this point, perhaps COVID is taking up a little bit less space. But I think in 2020, 2021, it was probably something that was very anxiety provoking and stressful for many of us. But I think one of the things to bear in mind is we all have this internal container, but when you live with a rare condition, a large part of that container is taken up just by living with that condition. So you need to bear in mind that your capacity for dealing with stresses is also impacted by the stresses of your condition. And some days that space taken up by living with lipodystrophy will be bigger. So what happens then when we have lots of stressors and their add-on? Well, sometimes that bucket overflows. And what that feels like is this experience of like, this is really overwhelming. I can't deal with this. So that is if you imagine if that bucket is overflowing. So how you counter that is to think that actually, are there certain things that you can say no to? Are there certain things that you don't need to be taking on and adding to? Another powerful way to look after ourselves is to learn to recognize the signs of when our bucket might be overflowing. And these are just some examples. And again, you might recognize some of these in yourself, or perhaps you can think of your own. But for example, noticing that you've become more irritable. All of a sudden, you anger more easily. Perhaps you're feeling a bit low. It's harder to get up and go in the morning. You're feeling less motivated for certain things, or perhaps things you used to enjoy don't feel quite so enjoyable anymore. Maybe your appetite's changed. Maybe you're finding that you're eating much more than usual or a lot less. You might be turning to drugs and alcohol more as a way to cope with those difficult feelings. Again, that sense of kind of feeling overwhelmed of this is too much. Maybe your sleep is disruptive. Perhaps you're finding it hard to get to sleep or to stay asleep. You might be experiencing anxiety. Perhaps you change your day-to-day. You might start avoiding people that you usually like to see, or avoiding certain conversations that are just making you feel uncomfortable. Perhaps you feel restless. The idea of sitting still is just impossible. Or maybe you've noticed that you feel a bit more tearful. Something comes up on the television and it sort of sets you off, as you might say. Perhaps your fatigue worsens. Or you might notice aches and pains more. And again, I'm not saying that these are necessarily linked to how you're feeling, but definitely the way our body feels definitely has an impact on mood as well. So what helps? So I already spoke about the importance of accepting feelings and not judging them or ourselves for having them. But another way is to practice living with uncertainty and staying in the present. So developing what we call these muscles for uncertainty, which is something that when you live with a rare condition, you really have to work quite hard to develop. And staying in the present, like small exercise like we did just to start off. There are obviously lots of different ways to do this. If that's not a way that feels comfortable to you, it may be about just trying to notice what's in your environment, just bringing yourself back to yourself. Also, a really important part is to build support networks. So that might be friends and family. I think we're all really good at knowing, who's a good friend when I really want like just a laugh, a good chat, or if I want to have a deeper conversation, do I have a friend or a family member that I can reach out for? So kind of knowing who is helpful, who is good for what you need in that moment. And also thinking about building, and I do mean building and see it as a work in progress, your relationship with your healthcare professionals. Sometimes that might be challenging, particularly if you've had a lot of interactions with them that have felt quite disparaging. But it is a relationship that is worth building because you may be seen by the same team over a long period of time. So it's important to create that communication, to foster that, and to be clear about what it is that you need from your team. Social media can be a useful source of support. You might come across people like Tom, we saw earlier, and also just sharing, connecting with other patients like yourselves. So it helps to feel less isolated in your experience. But I would just put a caveat there of just being mindful of social media, because obviously it can be a double-edged sword, and sometimes engaging too much with social media can actually impact your mood in a negative way. So just kind of being aware of how do you feel when you're engaging these posts? Does it leave you feeling uplifted and positive, or do you actually find yourself feeling worse afterwards? It's important to remember that you're not alone. And I think just looking around this room, it's really lovely to see everyone come together today and to know that there are days like today, but also, as I said, on support groups, social media, things like that, remembering that you're not alone in your experience. And to not be afraid to ask for help if you need to. So asking for help, as I said, might initially look like reaching to your support system, friends and family. But sometimes you might want to seek support or help from a professional or from an external service or a person that isn't directly connected to you, because sometimes it feels good to speak to someone that isn't directly impacted. So these are just some of the places that you might want to access talking therapies, for example. So you can ask your GP to signpost you to local services. You might speak to your hospital or specialist service. And also you could look to improving access to psychological therapies. So these are local services, often that have a self-referral mechanism. So if you find your local service, you can usually fill out a form online, and they can offer you usually around, I think, 6 sessions to help with sort of anxiety or feelings of low mood. Then it's important to know, obviously, to reach out to patient advocacy organisations that provide specialist service and information, and might be able to signpost you to other sources of support, such as Lipodystrophy UK and us at Rare Minds. If possible, you might consider accessing some private therapy with a therapist that has experience working with rare conditions or physical health conditions. If you do choose to do that, I would advise you to look for a reliable sort of directory. So looking at the registered professional bodies such as UKCP or BACP. And at Rare Minds, we're always happy to signpost as well, because it can be a bit of a minefield to know who is someone that you can approach, and what might be some of the questions you should ask to know if that professional is experienced or qualified in a way that would be helpful for you in what you're looking for. Also, don't forget that there are crisis services such as the Samaritans, which provide a really good listening service. So I know a lot of people often have this idea of Samaritans as being a suicide helpline, but that's not the case. They're very much a listening service. And the beauty is that they're open 24 hours a day, pretty much 365 days a year. So if you just feel that you are feeling quite distressed and you'd like to speak to someone urgently, and maybe it's 2 in the morning because you can't sleep, the Samaritans is a really good helpline. And then just lastly, I just wanted to share some other sort of hopefully helpful resources. So for things like general anxiety and mood, and these are more kind of self-help resources. There are a couple of apps that are helpful, such as Buddhify, Headspace, and Calm. So often they'll provide kind of mindfulness, relaxation exercises, things like that. You might also want to access a mindfulness course from Breathworks, which was specially developed for people with health conditions, pain and anxiety. So there's a link there. And then for fatigue or help with fatigue, I don't know if you're familiar with the spoon theory, which is just a way that has been used to describe essentially energy management. So you start your day with a fixed number of spoon, and how do you decide how you're going to use up your spoons for the day, knowing that things that most of us take for granted or consider basic, like making breakfast, having a shower, actually use up some of your energy reserves. So if you have a really big day ahead of you, how are you going to use and manage your spoons? And then the Oxford University Trust has developed a leaflet as well on kind of managing fatigue. And again, just for urgent help, obviously your GP, NHS 111, the Samaritans, as I mentioned earlier, and Shout is also a text service that you can use that works similarly to Samaritans, but is text-based. And then there's just a couple of books if you wanted to have a look at those. But I just wanted to point out as well that Rare Minds, we're developing a section on our website for some self-help resources, which hopefully should be out later in the year, which obviously are specifically designed for patients with rare conditions. So, thank you.
Thank you very much. You know, regardless of having a rare disease, mental health is really important, and there's not enough emphasis on it, although there's more emphasis these days, which is a great thing. But there are particular issues associated with living with a chronic condition that can make things harder. So thank you very much for that. Have we got any questions? Hey, everyone's tired. You got one?
Would somebody from my family, for instance, be able to get in touch with you or Rare Minds? They don't have lipodystrophy, but obviously they're concerned about me having it. Would that be?
Yes, unfortunately, as an organisation, Rare Minds, we don't provide counselling directly. As I mentioned, we do work in partnership with organisations. However, a lot of services do tend to offer support for relatives or carers. So I would inquire, perhaps ask your specialist if they're aware of any local services and whether a relative would be able to access that. Yeah,
we also have a lot of carers and parents and partners in this network. So, you know, maybe we can find a way to put them in touch. Any other questions? No? Great. Well, thank you very much.
Thank
Really
you for having
appreciate
me.
it. Welcome. So before I hand over to Siobhan, who's going to close up our session for today, I just want to say thank you so much for coming and being part of the day, and, you know, being honest and raw and open and sharing your experiences. We've had some fantastic speakers, and I don't know about you, but I've really, really enjoyed the day, and I've learned a lot, and hopefully we can do this again. As I pass over to Siobhan. Siobhan, as we all know, has done a fantastic job of organising this event. It's very, very much appreciated. She's outdone herself. I'll let her say a few words.
So, hi everyone, thank you for coming, and thank you for these, Becky. I just wanted to echo what Becky said. Hopefully you've all really enjoyed the day. I hope you've found something that you can take away with you. We are going to ask all the people that have spoken today if they can give us their slides and their contact details and information. So it will all go on our website, our social media platforms. But if there's any questions, then just ask one of us. We'll always help. There's several ways to contact us. We've got emails, social media. Just reach out and we can put you in touch with people and answer any questions, hopefully. So thank you. Thank you to all the team at Addenbrooke for supporting the day and coming along. Thank you to everyone who's travelled. I know some of you have travelled a really long way. So it's been great. It's been really lovely to meet. Hopefully I've got around all of you, but if I haven't, hopefully I will by the end of the day. And just as a last sort of thank you and goodbye, we'd like to buy you all a drink. So there is a bar outside that are setting up now. If you'd like to go over and just hand in your lanyards to the bartenders, then they will give you a drink. So thank you and enjoy the rest of your day.
Before I forget, if anybody wants to get involved with the charity in any way whatsoever, you don't have to sign up for a minimum amount of time. Any help is gratefully received. So we'll be sending a reminder out, but please get in touch with us. The more support we've got, the more we can do for you wonderful people. So thank you.